influences everyday lives of older person. The second one for me is to highlight the gap and the barriers in the implementation, particularly for women, informal workers, and marginalized older population. And the third is to identify the practical opportunities to strengthen healthy aging, social protection, and inclusive development across the region. Our emphasis today is on a bridging policy commitment with on-the-ground realities. Then, when we briefly talk about the scene for two key regional insights, that's what I wanted to focus on. This is also nothing new. By 2050, almost 2/3 of world's population aged above 60.
I'm unable to hear him. Has he got muted, or is it something with my system?
We can hear him.
We can hear now. I think your system might.
Okay, so what I was trying to talk about is 2/3 of the world's population aged above 60 will be living in Asia, and many countries in this region essentially are aging faster than they are growing economically. With the family support system remain the central, and formal social protection and the long-term care system remain uneven and underdeveloped. This is a matter of concern, especially in low and middle income Asian countries. The trend, these trends, in fact, raise urgent questions about the sustainability, equity, and the readiness of public policy to respond to longer lives. With this, I'm going to primarily introduce the panelists. Now, it is now my privilege to introduce our panelists. Each brings a complementary perspective from the policy, research, and practice. Let me begin with Professor T.V. Shekhar. He is a professor at International Institute for Population Sciences, Mumbai, and a leading expert in population aging, social demography, gender, and family studies. He has played a key role in major national and global studies, including the longitudinal aging study in India, LASI, and the SAGE, and has published extensively with over 120 research articles and numerous edited volumes. A former Fulbright Nehru Senior Fellow, Professor Shekhar has held various positions, or rather visiting positions, at Oxford Brookes University and Lund University, and has provided significant leadership to the field, including serving as a president of Indian Association of Social Sciences and Health. Let me welcome, on behalf of the conference event, Professor Shekhar. Welcome to this event.
Thank you, Dr. Anish.
Now I'm moving to Dr. Niral Shah. Is a triple board certified surgeon and a clinical care specialist and a fellow of American College of Surgeons, with a training from leading institutions including Weill Cornell, Harvard Medical School, and Upstate Medical University. A surgeon entrepreneur at the intersection of medicine, innovation, and business. He has successfully founded and excited multiple early stage technology and life science companies. Inaugural biodesign and innovation fellow and an MBA graduate from University of Michigan. Dr. Shah also brings a deep humanitarian experience, contributing to the global crisis and trauma care intensive setting in Haiti and Ukraine. He, while continuing to advance innovations in the healthcare. Dr. Niral, welcome to this panel. Moving to Dr. Anil S. Bilmail. Is a public health physician and an associate professor at the School of Public Health, JSS Academy of Higher Education and Research in Mysore, working at the intersection of health, longevity, and social innovation. With over a decade of experience spanning WHO, UNICEF, academia, and the community health system. He integrates policy insight with the grassroots level implementation. He has authored more than 30 peer-reviewed publications, mobilized significant competitive research funding, and developed innovative frameworks such as the Panchatantra model for longevity and Meta-7 early metabolic risk score, contributing to the predictive and preventive approaches to healthy aging in India. Welcome, Dr. Anil.
Thank you.
Now, the last panelist, Dr. Malti Jaswal, is a founder of Inspringing Seniors Foundation, a Delhi-based non-profit dedicated to promoting healthy and purposeful aging by enabling seniors to actively contribute to society. With a prior experience as a senior consultant at World Bank and advisor to India's National Health Authority during the rollout of Ayushman Bharat, she brings strong policy and system expertise to aging sector. Trained at Delhi University with a leadership background in insurance sector, Ms. Malti is a strong advocate for reimagining India's silver population as a vulnerable national asset through the awareness opportunity to the innovation. Welcome, Ms. Malti, to this one. Now, I'm handing over to Lily Rose for a couple of minutes time. Lily, are you there?
Yes, sir. Okay, good morning, everyone. Now I would like to introduce our moderator for today's plenary session, Professor Dr. Anil Krishna. So he is a distinguished public health expert with over 30 years of experience in health system strengthening, health financing, and health policy across Asia and Africa. He holds a PhD in public health with a specialization in health economics. His work has focused on universal health coverage, primary health care, maternal and child health, and non-communicable disease management with significant policy impact in countries such as Myanmar, Cambodia, Vietnam, Indonesia, Nigeria, Liberia, Rwanda, Chad, and Guinea. He has held prominent leadership roles, including Director of Global Health at the University of Global Health Equity, Rwanda, and Technical Lead for Health Systems at HelpAge International in Myanmar. Professor Anil has collaborated with global organizations like UNICEF, USAID, GIZ, European Commission Gates Ventures, and the World Health Organization. He served as the co-chair for WHO Digital Health Competency Framework on Digital Health Leadership. He also served as an associate dean at the School of Public Health, SRM University, Chennai. He is known for fostering cross-cultural leadership, capacity building, and innovative health solutions. Professor Anil continues to influence global health policy through his active roles in advisory boards, steering committees, and international health forums. On to you, sir. Thank you.
Now, before I get into the formal panel, I think I'm audible to you all.
Yes.
Thank you.
Yes.
So, yeah. See, as we move to the formal discussion, let us say I'm going to set some ground rules, time discipline, which is critical. We all know that. And also, we would promote interactive engagement and the entire concept through the policy lens. That's what we are going to do it. With that, I'm going to, in fact, start the first round of the discussion, which I would expect all the panelists to give your thoughts on a question within the 3 to 4 minutes slot. See, the question, it's a burning question remains today is, what is the most significant policy impact on aging in a particular region or a country, and what challenges or opportunities remain? These are the thing which we are going to discuss for the first 15 minutes. Let me start with the Professor Shekhar. Professor, over to Professor Shekhar for your thoughts.
Good morning, and thank you, Dr. Anil. I know that aging issue is receiving a lot of attention, both from researchers, policymakers, academia, and even the voluntary sector. And of course, it's $1 million question you have asked. What are the main challenges? There are many challenges for a country like India, where we are fast experiencing aging transition. And by 2050, we'll have around 320 million elderly or senior citizens in our country. If I have to focus on one issue, I would suggest, or I would pick up the social security for India's elderly, because vast majority of them are very poor, no savings, no income, and not even health insurance. Now, the government started providing a meager monthly pension, what we call old age pension, to large number of elderly. It was called a national old age pension scheme, with the central government contributing a small amount and asking the state government to contribute. Now, when we did the longitudinal aging survey in India, it is a pan-India survey covering 73,000 older adults across all the states in India. We found that nearly 1/3 of elderly, poor elderly, or those belong to the BPL households, below poverty line households, are currently receiving this pension. But that also means that another 2/3 yet to get to the pension. So this is a big challenge. And the amount is also very meager. If I have to convert into US dollar monthly, around $6 in some states it may be $20, very small amount. And it varies in 400 rupees in Bihar to 3,000 rupees in or 2,000 in Telangana or Goa or Kerala, 2,000 rupees, big variation. So providing this basic necessity of old age pension to the poor and destitute elderly is one of the biggest challenges. Government's doing a lot of effort. State governments also doing. Some of the state government are implementing various programs. Good example is coming from Kerala state. But still, lot more need to be done to protect this vulnerable segment who are not having any income, any pension, any savings. And since the longevity is increasing, they are also facing lot of health problems and related health expenses. So I think this is one area in which government and other agencies need to focus to take care of this poor and destitute elderly, and their number is quite high in Indian context. Thank you.
Thank you, Professor Shekhar. I mean, which is very critical. What you said was social security. When we look at the countries, Western countries, they are more focused on social security, and 2/3 are yet to get the pension under BPL. Which is very critical to this one. Now, I'm just moving to Dr. Niral. With your existing international experience with the US and other countries, can you just give your thought on this particular question?
Thank you again for having me on the panel. The biggest problem and the biggest policy changes, especially in the last 5 to 10 years, has been the dramatic reductions of government spending, which has substantial implication in the aging population and the healthcare delivery. You see this in the US, you see this in the European Union, you see this in the ANZ region. The one outlier may actually be China, but I'm going to put a little asterisk there because that data is opaque and we don't know what exactly is happening. So let me put some pants on the problem by giving specific numbers. In the proposed fiscal year of 2026, the National Institutes of Health, which by far worldwide is the largest purveyor of research grant funding, there are proposed cuts of 39%. For the National Science Foundation, which does very much of the bench work, the proposed cuts are 56%. So now you're looking at a $46 billion shortfall and a $27 billion shortfall. If you look in the European Union, the shortfall is probably going to go down by about 25% from 90 billion euro down to about 65 billion euro. So again, these are large cuts. What is the impact? The impact is that researchers, and by definition, health policy that comes in 10, 15, 20 years, has to find other sources of funding. So when there are proposed cuts, is it going to be the Gates Foundation that ends up filling in the tab? Is it going to be H-Tech and private enterprise? And I think that's where the world is going to go to answer the second part of your question, which is what are the opportunities? So what had been the purview of governments is now probably going to go into a public-private sector partnership that moves the ball forward. And I don't think that's going to be just in the US, but you'll probably start to see similarities in the European Union, ANZ. I suspect in India as well, as I look into what's happening coming forward. Longevity, by definition, is a long game. And I say that with pun intended because the research that's done, the effects are seen 20 to 30 years from now, when there's no political will to put money in the problem on a short cycle election. There has to be a new funding source that does it. So the H-Tech market, in my humble opinion, is probably going to be the biggest purveyor going forward in the longevity space.
Yeah, thank you, Dr. Niral. It was quite interesting. In the Western countries, there are substantial spending, reduction, which invariably affects the entire world in terms of research, which is a fact. We can't, in fact, ignore this one. So one example for that is the USAID, totally wrapped up, dismantled, with which, essentially, put a burden on the poor countries. That was one of the things, because the USAID is being giving a lot of money for the research, which eventually vanished, which is a very critical thing to think about, and how we are going to locally mobilize to strengthen the policy. Excellent. And yeah, thank you for that, your thoughts. Now I'm moving to Dr. Anil to give your thought, essentially talking about your community-based experience and things like that would be much more interesting to the audience. Over to you.
Thank you, Dr. Anil Krishna. So from an Indian perspective, the most significant policy impact has been the formal recognition of aging as a legitimate public policy issue. For a very long time, aging in India was treated almost entirely as a family responsibility, something which is private, informal, and invisible to the systems. So the introduction of the national policy for older persons and later the national program for healthcare of the elderly, it marked an important shift. So it acknowledged that aging has health, social, and economic implications that require state responsibility. So this recognition has led to some tangible actions. We have some geriatric clinics now, district level services, and more recently, the integration with the primary care through health and wellness centers also. So these steps matter because they respond to what are national evidence, particularly the LASI study, which clearly shows a high burden of chronic diseases, disability, and dependency among the older adults. However, the challenge is that most of this policy impact is concentrated at the late stage of aging. We are responding when aging has already manifested as a disease or disability. The WHO's healthy aging framework reminds us that healthy aging is about maintaining functional ability, not merely treating illness. So that distinction is crucial. So the real opportunity for India now is to move upstream. So to think of aging not as a problem of old age, but as life course of process, like what we did in maternal deaths and infant deaths. We came up with the life course approach, the RMNCH program, reproductive, maternal, newborn, child, and adolescent program. So like that, we have to think aging not as a problem of old age, but as a life course process. Countries like Japan and Singapore demonstrate that when aging policies are embedded in daily life, in how people move, in how they socialize, how they stay engaged, the outcomes are far better. So India has built the foundation, but the next phase requires redesigning the systems around how people age, not just how they fall sick.
Yeah, thanks, Dr. Anil. I really like the way which you said in legitimizing the aging, which even later stage they recognize it as. And the second one is talked about the upstream, like the one which we what do we call it as the life course approach adopted in other vertical programs in India as well. Very good. Let's further explore later. And now I'm moving to Ms. Malati, ma'am, because you have a different experience in the NGO sector, and most importantly, the insurance sector, which is very critical to address the issues related to the aging. Would like to, love to hear from you. Over to you.
Yeah, thank you very much. And first of all, my thank you to sincere thank you to Longevity, team to giving me that opportunity to be in the company of such learned professors and doctors. I would speak more a little bit from the lived experience side, of my parents and me. I turned 60 last year. And how are we viewing longevity? The lens with which we look at old people. Are we still looking at them for welfare, or are we looking at them as a development, opportunity? I think that lens, first of all, needs to be changed for the policies to then from the lens, perspective to the policies to the action. As I think Dr. Anil mentioned that, at least there is a recognition. Last year, Niti Aayog also brought out a paper on senior care reforms in India, and they are in the process of bringing the next operational version of what it would be, to look after this segment. Let me bring a little bit, beyond the numbers perspective on the sheer numbers of aging. If we don't act now, the negative impact on our GDP could be 0.04% to 0.08% if we do not act upon, right policies and create the right policies and environment and opportunities. We did a paper on active and healthy aging with Vicky, and that's where we did some, did these numbers. On the other hand, if we look at longevity, if we convert longevity into a dividend, we have the potential of gaining around 300 to 500 billion annually going forward. So there is a very much an economic case. It's a social case. There is an economic case. There is a demographic case. In India, we have been very blessed to have a very young population, but it would not be so going forward, right? So the focus on the youth, the focus on the children is all right, but the focus on the silver tsunami which has happened has somehow missed our policy makers, and we still have time to catch the bus, I would say. If we would act now, we are in the middle of UN decade of healthy aging. So there is a momentum given from the UN, momentum gaining from the Niti Aayog report, and as I think Dr. Shekhar, or I think, or Dr. Anil was saying that there is a lot of now interest in longevity. There is a lot of interest in aging. So I think that the stage is set now. The most recent, policy perspective that came, Ayushman Bharat inclusion of 70 plus, individuals universally under Ayushman Bharat, which is an excellent step by any means. It is not adequate and complete, but it is a step in the right direction, I would say. The elderly need many things: social protection, insurance, as you said. They require insurance, not just the hospitalization insurance, because most of their spending may be on the medicines and bills. But then medicines and bills is fine. But our focus from pills to prevention to promotion of holistic aging is what is required. And it's not just the medicine part, it's the social. I mean, in India, we talk to geriatrician and they're not even familiar with the concept of social prescriptions. Leave alone, talking about it, leave alone giving it to the people, mentioning it to the people. I mean, very senior geriatricians were not aware of the concept called social prescriptions. So we have a very long road to go. We have a very long canvas to fill. But I guess this is the right time. This is a time that we should act now if we don't want to miss the bus. And in India, I would just take one more minute that we have been very smart with frugal choices that we have made, very frugal. And so for us, the good part is that we have good penetration of mobiles in India, telecom in India, that internet is cheap in India. So making use of the resources that we have, how do we make aging as a better lived experience is what I think is the need of our. I'll rest here now. Yes, thank you.
Okay, thank you, Malti ma'am. It was very, critical points you have raised here. One is about, policy, looking at aging in the different lens, which is critical for the policymakers and administrators. Now, one of the interesting thing which you mentioned here is, impact on GDP. It is not too late for us to address that. I'm very, very much interested in this particular one. I'm sure this conference will come up with some of the suggestions where that is going to be one of the areas where we need to address. Thank you very much. And thank you very much for your rich insight. Let me now deep dive into the dialogue. I'm going to reverse the, the order. Let me start with the Maldi ma'am. To continue with your discussion now, just before, what are the innovative opportunities exist in digital health, social insurance, and intergenerational programs? Can you briefly touch upon this with your experience on board?
Thank you very much. And thank you very much for reversing the order, for giving me the opportunity to speak first. I would speak from the perspective of what we are trying to do in the nonprofit that I represent, Inspiring Seniors Foundation. So what we realize is that there is a, in the senior citizen segment, it's not one size that fits all. There are, seniors in the age group of 60 to 75 who are fairly energetic, healthy. And in any case, in India, we take seniors 60 above, whereas internationally it is 65 and above. So 60 to 75 is a fairly energetic group. And then there is a, then there are, vulnerable, poor, vulnerable, rural and urban, digital savvy, non-digital savvy. So it is a very, very, heterogeneous group. Their basic requirements may be the same, but their cultural context and the perspective would be very different. So what we realize is that let's say that in India, out of the 10% population that we have, there is a majority who is in rural areas and a majority in the vulnerable section, but there is a very sizable section which is above the poverty level, and which are the retirees and the educated seniors who entered the economic space in the late 80s or 90s when the economy opened up. So that's a cohort which represents a very rich resource pool for India. And that's the focus of our foundation, that how does this resource pool work for the other elderly, who may not be in this cohort, but then they help the other elderly. How this cohort can have, society programs for giving back to the society, teaching children, giving mentorship to youth, or, life skill guidance, in the age of AI, knowledge is at the click of a button, but wisdom is not still at a click of a button, right? The what you earn over 40 years cannot be taught by any AI engine, right? So we have programs where we realize that there is a wealth of knowledge, where there is a wealth of wisdom, and there is a very big part of Bharat where the children are still struggling with a very basic level literacy, let's say, a very basic level of math, science education, English education. So what we are trying to do is to create these programs which enrich the life of senior. They make them feel purposeful and happy. And on the other hand, there is a beneficiary about a youth or a child, who gets mentored, who gets spoken to be very confidently, whose motivation goes up. So these programs are what we are exploring. Along with that, we are also exploring programs which give social connections. As you grow old, your connections become less and less. So and we are trying to use the telephone and the use of internet in a big way, so that they become digitally inclusive by virtue of our programs. So we don't have to teach them digital inclusion. They become digitally savvy just by participating in program. Even if it's learning art, even if it's music or a book club, they become participant to that. Third, we also use this telephone, again, this mobile instrument, for how many steps did you take today, their mobility, their strengthening exercises. So we make good use of this digital infrastructure which our country has, at a very reasonable cost and a good penetration to address some of the issues that seniors face, particularly in urban cities, urban areas, and smaller towns. We have not. I mean, I am not the I wouldn't touch base on the rural side of the the divide, because we have not done those programs as yet, but we do intend to do that in future. Thank you.
Yeah, thank you, Malti ma'am. Which was again an interesting fact. We have a wealth of information available with the older persons and how we are going to use them to build the skills of people in the society, which is one, and the use of digital. You used a word wealth of wisdom. I mean, something needs to be really thought of. Thank you for that. Now, I'm moving to Dr. Anil. How can the government, civil society, and the communities work together to ensure dignity and equity for older people? I would like to hear your views with your current experience.
Thank you. Thank you for that question, Dr. Anil. See, dignity in aging cannot be delivered by any single actor. So governments play a critical role in creating the enabling environments, age-friendly cities, accessible transport, safe public spaces, and primary health care that can focus not only on disease, but on function and also on independence. So the civil society is equally important because some of the most painful aspects of aging is loneliness, isolation, and loss of purpose. And these cannot be treated medically. NGOs and community organizations often have the trust, flexibility, and the local presence which are needed to support caregivers. And they can rebuild social connections and reach those who fall outside of these formal systems. So communities are where dignity is either preserved or lost. So WHO emphasizes the supportive environments as a core pillar of healthy aging. So this means neighborhoods where older adults can walk safely, interact socially, and remain contributors rather than the dependents. So intergenerational engagement is especially powerful here. When older people are valued for their experience and participation, and younger generations benefit from that interaction, then equity becomes lived rather than being theoretical. So true dignity in aging comes from belonging and not just benefits. So many of international universities actually give credits for students during summer internship to be with aging population and have that intergenerational experience sipped in also. So I think these are some of the ways which we can actually preserve the dignity of people.
Yeah, fantastic. See, dignity cannot be delivered in a single mode, which is the catchy word from this one. Caught my attention caught in that, and the last one what we mentioned about equity is lived. You cannot address equity without having experience. Yeah. Thank you very much for the insightful thoughts on this one. Now I'm moving to Dr. Niral. Where are the biggest gaps between evidence, policy, and practice? With your international experience, can you throw some light on this?
Sure. Thank you for the question. First, let me start off where the biggest gaps are, both in the Western world as well as in the emerging markets. So even in the Western world, you have a fragmented healthcare system, meaning someone goes to hospital A, they may have senior living or ancillary care done at system B, and then you have movement that's going on. So they may be moving from New York City, then to Los Angeles, where their children live. Now you have a whole new set. So that's one of the bigger gaps that is potentially attainable. Another big gap between evidence and policy is something that Malti talked about, which is the evidence paradox or knowledge paradox. We have the data, but not everybody has access to it. If you're not digitally native, you may not have access to it. Now, I'm going to move to where there's opportunities in the practice. There's a company that one of the groups that I work with invested in. It's a very low tech thing. So what they're doing is it's essentially an Uber for pharmacy. Many elderly cannot get the medicines they need because they have no access to get to the pharmacy. So instead of them getting to the pharmacy comes to you. The healthcare system puts the order in and sends it right to the patient. What does that do for the healthcare system at large? It prevents readmission and decreases the loss of quality of life when chronic diseases become too burdensome for the patient as well as the family. When you look at a couple of areas that have been doing really well, it's when you look at long life cycle changes. So Vietnam has done a really good job of having the youth look into what they're going to need to maintain their health into old age. And that's going to become more and more problematic as demography changes. In India, you already see a decrease in the birth rate. In the US, we have gone below birth rates for maintaining our population. You look at South Korea or Japan, it's actually inverted. So the number of elderly is markedly larger than the youth, right? So this is going to be a burgeoning problem, and those gaps need to be fixed in terms of fragmentation.
Thanks, Dr. Niral, for your view. One of the things which I really liked, pharmacy comes to you for this one. But a country, Western countries can easily manage that. But the country like India, I don't think that is going to be a viable solution for India. But the Western countries are essentially.
Well, I'm going to push back a little bit. There's probably other business models that can be done. So I think in the Western countries, we have integrated healthcare systems that are vertically integrated. You don't have that in India. I foresee that maybe occurring 20 to 40 years from now. It's already happened in the US because our birth rate is now terminal.
Right.
It's not that way in India. It will become a problem, and I bet you that's where it's going to go.
Thank you. And fragmented health systems, that is also critical in the health systems in the low and middle income countries. Okay, so thanks for the thoughts, and I'm just moving to the last question to Professor Shekhar. What policies have worked best in translating aging needs into action? With your experience, and you've been chairing the Niti Aayog for some time, or one of the members of the Niti Aayog, where the India's policy dialogues have been happening. So how do you answer this particular question?
Dr. Anil, if in Indian context, specifically on Indian context, because most of our work and research is essentially focusing on senior citizens of this country. There are a lot of policies and programs introduced by both national as well as the state governments. For example, the National Program for Healthcare of Elderly, implemented by Ministry of Health. I think Dr. Anil mentioned about that. It's a very ambitious program where opening the geriatric centers in medical colleges, geriatric wards, and coming down to the primary health center level. But we need to do a lot of work. But I strongly say that there is an increasing realization, even the government circle, there is a need to focus the healthcare, geriatrics and gerontology in our medical curriculum, in our medical colleges and hospitals. And we have very few specialists in this area. So that is one area where there is an attention, but we need to do a lot more. And about the rights of the elderly citizens, in 2007, Indian Parliament passed a landmark legislation called Maintenance and Welfare of Parents and Senior Citizens Act, which says that it is a duty and obligation of the children to look after their parents. And even after inheriting the parental property, wealth, house, whatever it is, if they are not treating their parents properly, under this law, there is a provision revert back the property to the old parents or grandparents. Now, you can see a lot of cases coming up on this everyday newspapers. Many parents or grandparents, out of desperation, it's a very difficult thing to go to a court or a tribunal against your own children and staying with them. It is a really a difficult and painful experience for most of them. But still, when you are resorting it, that also indicate their situation is there. So in this context, the intergenerational bonding become very crucial. And I also appreciate the point raised by Dr. Malati Jaswal about we always consider the elderly as a dependent population, liability, but there are a lot of senior citizens, particularly in urban India, who have the potential to contribute, who are enough money, you have skills, expertise, and willing to contribute, but they need a channel to work for that. So to tap this silver dividend, or we need some organization, and I think organizations like Inspiring Seniors Foundation and many other organizations are working on that to tap this untapped potential of India's senior citizens who are educated, skilled, economically better off, and willing to contribute, and they have health on their side, particularly those belong to 60 to 75 age group, mostly in the urban India. So that part, I think one area where we need to focus that government alone cannot do. The voluntary sector, private sector can do a big role in that. Thank you.
Thank you, Professor Shekhar. I'm taking the last point which you touched upon, said tapping the untapped resources, which is critical. And we all know that. See, in a country like India, where the retirement age, official retirement age starts from 55 to 60. But if you look at the Western countries, in fact, they're starting their career at that time. So, because of the resources and those kind of things should essentially tap in a country like India. Thank you very much for the panelists for providing the rich thought and thought-provoking discussion that offered vulnerable, rather the valuable insight into the practical perspective. With that, I'm turning to the audience. We have almost, in fact, we allocated 15 minutes. We have only 10 minutes to take the questions from the audience. Over to Lily. Lily, did you get any questions? Or the audience, you can directly ask questions to the panelists directly. Malti ma'am, you were going to say something?
Yeah, I would just like to add to Dr. Shekhar that, as a policy, Government of India, government should be looking at something like a national silver service, where the seniors can register and be available to startups, to voluntary organizations, to society, to n number of possibilities. But some kind of a small NGOs like us can only do this much. But a government program like that, and imagine Modi ji speaking at a platform and opening this platform, like, so what would be the enrollment and what would be the movement that would happen, about volunteerism, about economic contribution. And I think one more point about dignity, relevance is very important part of dignity. So the policies have to make the seniors participatory and relevant, in the scheme of things. Respect is one thing, but relevance is more important in today's context. Yes.
Okay, thank you. It's a good point. So there are some questions. Srinivasamurthy, he has got a question. You're going to ask to whom? First, you talk.
I want to make a comment. I am a retired professor of psychiatry from National Institute of Mental Health and Neurosciences.
Okay.
I want to make a comment. Can I?
Sure.
Yeah. I think very important discussion, but one area which has been left out by all the speakers is the community resources that are there for active aging. I am specifically referring to spiritual resources, because at this moment I'm working as a Dalai Lama Foundation fellowship, looking at the spiritual relationship, spiritual resources which help in aging, like the idea of vanaprastha. I think this is very, very important because we can't talk about everything as a loss. As Swami Ranganathanji says, think of it as a transition and prepare for it. And I think we need to now again convert this philosophy into practice. That's what I am doing. And I would like the members to respond to that. Thank you.
Yeah, Srinivasan sir, it's a interesting fact that people started ignoring. By the way, the entire globe is turning towards yoga and other spiritual sorry things. But anyone in the panel would like to give some thoughts on this?
Dr. Vinod Kumar, he is a very senior geriatrician from AIMS. He has, created a 10 pointer index for healthy aging. And spirituality is a very important part of it. It could be any way. I mean, being spiritual doesn't mean religious. It is being spiritual. I mean, connecting to the higher self. So I think what Dr. Srinamurthy has said is very relevant and is actually documented. It's documented and researched area also.
Yeah, okay, good piece of information. We all need to be. And Dr. Niral, do you have any thing to say?
So sorry to interrupt, sir. There are some questions in the WhatsApp group, I think.
Oh,
I
okay.
just put it in there, sir.
Yeah, can
Your
you?
reference.
It is in the chat.
Yeah, in the WhatsApp group, I put it, sir.
Okay, WhatsApp group. Okay.
Okay. Let me bring them all to you. How do I do this?
So while we wait, Dr. Krishna had asked for my 2 cents, my 2 cheap cents, as it were. I think spirituality is a very important part. You're starting to see it in the Western world more and more. I think one of the big things is spirituality and community go hand in hand, and that's where you're probably getting the biggest upswing. So definitely appreciate that comment.
Oh, thank you. And there are some questions. I'm going to read out the questions. First question is for Professor Shekhar. What is the role of family and social security? Kids and extended families. Is there a norm or a policy perspective to empower them to take care of their elderly? This is a question for you, Professor Shekhar.
Yes, of course, you know that in traditionally and even now, the family is the major caregiver supporter for elderly Nitya. 95% of our senior citizens are living with their family, spouse, children, or even grandchildren. But over the years, with a lot of social and economic changes happening, large scale migration of the youngsters, many of these elderly are left behind. And some of them, according to our last study, around 7% of elderly are living alone, one single person households. And it is much higher in states like Tamil Nadu and Kerala, around 15%. And most of these are elderly widows. So there are a lot of issues coming up in the family level. There is a lack of intergenerational bonding and need to take care of the elderly parents legally as well as socially and emotionally. They need the support. So various issues, though there are no government policies, but there are in many countries where the children were asked or adult children were encouraged to stay with elderly or their elderly parents were allowed them to stay with them, promoted by various benefits and tax cuts and all, encouraging the children to stay with their families, all of the things. But of course, in India, we are not thinking anything like that. And the Western model of long-term care will not work in India. We should have Indian model of taking care of parents or grandparents based on family values and family systems. That is the only way to address these challenges, because our numbers are quite high. And a person at the age of 60 now expected to live another 20 years more. The life expectancy at 60 is another 20 years they are going to live. So it's a big work ahead of us, and we are not economically and policy level prepared to meet that challenges.
Okay.
So, of course, family will play an important role, and provided by the government and other organizations also support and come up with some good policies and programs to encourage the family values, intergenerational bonding, living together, and many other things. Thank you.
Okay, great. Thanks, Professor Shekhar. Now, the next question is to Dr. Niral. Not every country has startup infrastructure such as accredited investors and mentors. In such context, how do you see age tech is going to flourish?
Thank you for the question. Great question. So emerging markets actually are a very big hotspot for investors from even me. So I work on behalf of the Indus Entrepreneurs Thai, which has multiple chapters even in India, where we bring a lot of that work there. Another company that I'm an advisor to is called Emerald Bioventures. One of our key linchpins is taking not necessarily data, but learnings from emerging markets, India, Philippines, Indonesia, wherever we can to bring it back. And we're willing to fund in those institutions, specific institutions, if they're small colleges, things like that, or smaller companies, because we can take more shots on goal. The crux of the question probably asked is how can, if I'm an entrepreneur or startup, or if I'm a small researcher, what can I do? Believe it or not, there's a bigger democratization that's happened now with some certain foundational things. So you have ubiquitous computing, you have access to things like vibe coding, all these things. So the cost of bringing that down is actually much lower than people think. And it is going to take a little bit of time, and that's a policy change that's probably going to be done at the governmental level of whichever recipient country it is, whether it's the Philippines, Indonesia, China, or not China, India, Mexico, Nigeria, wherever. And you're starting to see movement in that range where they're keeping things internal.
Yeah.
Hopefully that answers the question. If there's any clarification.
Yes, precisely. You have answered the question. It is, something new for a country like India. I think it is, as you earlier mentioned, that say 10 years or 15 years down the line, we will be, in fact, working on all those things. Thank you for that. Now, next question is for Malti ma'am. In light of the recent advancement of health insurance for seniors across the country, is there a room for social prescription? Essentially, they are talking about a policy by the government, such as engaging the seniors, for example, mentoring younger generation and rewarding them financially or social protection, etc. This is a question for Ms. Malati.
Sure. I think that's a very, very relevant question. And how can government policies encourage, the giving back to society or economic contribution of seniors? Many of us might have seen the movie Intern. And that person is very, he is educated, is, retired, and, he's just looking for an engagement, for a purposeful engagement where he can be contributing. So government can definitely, promote. And then in our work, we do come across seniors who could do well with some additional income besides their own savings or pensions. And these programs by the government, where they could be, it could be incentives, it could be tax refunds, it could be any form of encouragement. But a government policy would definitely help in bringing a huge fold of economic activity into the senior segment. As I had mentioned that, a simple concept like National Silver Service, it would just unleash the platform for all the seniors to contribute and be available to, startups cannot afford expensive resources, for example. It could be accountant, it could be banking, it could be any area, that they could be coming from. It could be teachers or, mentoring and guiding comes very natural to a elderly. I think so I think that way there is always a two-way, a benefit program that can happen. So I totally agree with that government could be promoting this. Social prescriptions is something which, where the doctors have a more role than a government program, government as such. like social prescription is linking a senior citizen or a senior citizen to what would be good for his or her mental, physical, emotional, cognitive health. It's a linkage, it's a linkage by the, healthcare workers, which is done by that. So it could be referring them to, okay, I mean, all of them say you should do walking, you should do gardening, you should do, but then beyond that, what are the avenues available, structured avenues available, is more for the healthcare workers than for the government, I would say.
Okay, thank you, Malvi ma'am. Now there is one
Yes.
more question that is not been directed to anyone. So I'm just reading the question. Anyone would be interested, you can answer the question. What do you think about the government policy to support caregivers as a complementary policy to maintain to the Maintenance Act? This is a question. I think the apt person is Professor Shekhar. You could be in a position to talk about that.
Yeah, the caregiving has emerged as a major issue. There are many policies recently by the government to train the caregivers, and even approved certificate or diploma courses in caregiving training and other things. Recently, I was told that the government of Japan reached an agreement with government of India where they will train the caregivers. Government of India will train caregivers and send them to Japan. Of course, they have to learn the Japanese language as well to work there. So there is a lot of scope in that area, but we don't have a proper training curriculum, methodology, or even a syllabus system or a degree or diploma programs. Here and there are few courses. But that is going to be a big area to regulate this market in a big way with the trained professional caregivers. And there is a demand for that. So there are some efforts, but I think government need to do much more to support this activity. I think Dr. Malati Jaswal can add some more points with her experience in this field.
So I think incentivizing caregiving, I think the Maintenance Act is to look after the parents. And if you're looking after the parents, are there some incentives available to you as a caregiver? It's a very balanced approach. I would say nobody would deny that. It's a government policy that can help that intervention to give a balanced perspective. And caregivers definitely need all the support in the world, emotional, financial, legal, to make it happen, because caregiving itself is a very I think is an occupation which can break your back, literally, looking after the elderly. It's a societal issue which we will be emerging, which has already emerged, but it is going to emerge even a very bigger way. We need to tackle it. Yes.
Okay, thank you. And we have almost reached the fag end of this one. There is one question which it is food for thought for everybody. I'm going to read it. India has a good home delivery. I mean, India has very good home delivery services or last mile delivery, like given the example of Blinkit and Zomato. How can we integrate the policy point of view on prescriptions are being delivered through similar service? This is related to Dr. Niral's point on the policy to you. It's a food for thought, but that requires a lot of discussion, debate, and everything. As we have almost reached the fag end of the this one, let me thank our panelists and the audience today. For successfully completing this one. Today we heard about both progress and present and the gaps in the aging policy. To come to some of the takeaways, I just would like to give 3-4 points on the takeaways from this panel discussion. One seems to be the policies to engage family bonding and shorten the intergenerational gap. That is one of the outcome we could propose, eventually to the policymakers. Promote economic involvement among the seniors, which is a chance to give back. That is another point which needs to have further debate and discussion. The Indian challenge of training the caregivers effectively. that is another point which would be a potential policy question. Incentivize the caregivers and provide a full support. These all are some of the points which came into my thought. I would like to just flag this one. So with this, thank you all for being part of this one. We really enjoyed it. And finally, please join me appreciating our panelists for their wonderful comments and the contribution. Thank you. Thank you very much. And over to Shashank, sir.
Thank you, sir. Thank you so much. Thank you, the panelists, for giving us your time and more importantly, your insights. Thank you so much, sir. And thank you, Malti ma'am. Thank you, Shekhar sir, Anil sir, Bilamil sir, and Anil Krishna sir, and Dr. Shah, Niral Shah sir. Thank you so much again. Divya, if I understand correctly, our next session will be starting with the introduction of the chairs. Is that correct,
Yes.
Divya? Okay.
Yes, sir. Lily will take over and
Okay.
welcoming the chairs for the next session.
Okay. Okay.
Thank you all.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Thank you. Lily, can you start?
Yes, yeah. Okay, so I'll be introducing our chair for the session. So I would like to introduce Professor Dr. T.R. Dilip. So he has nearly 20 years of experience in researching and global monitoring of maternal, child and adolescent health in low and middle income countries. Dilip sir works as an associate professor, Department of Family and Generations, International Institute for Population Sciences, Mumbai. He has the experience of serving World Health Organization, Public Health Foundation of India, Center for Development Studies, Thiruvananthapuram Ministry of Family and Health and Family Welfare, and CHAT Mumbai. He has expertise in implementing the WHO's Global Survey for Monitoring Implementation of Maternal Death Surveillance and Response, MDSR, Global Implementation of Integrated Management of Childhood Illness, IMCI, Global Adult Tobacco Survey, GATS, and WHO STEPS. Dr. Dilip's ongoing research projects related to population and health-related issues are funded by Ministry of Health and Family Welfare, Indian Council for Medical Research, ICMR FORT Grant, and World Cancer Research Fund.
Thank you, Lily.
Thank you.
Thank you, sir.
So, am I audible?
Yes. So, Lily, you have to introduce the second chair, Dr. Dhananjay Bansud, also, in few words.
Okay, yeah. It's my pleasure to introduce Dhananjay, sir. So Dr. Dhananjay Bansud is a professor at the Department of Public Health and Mortality Studies, International Institute for Population Sciences, Mumbai. So prior to joining IIPS, he was working at the Population Research Center, Institute for Social and Economic Change, Bangalore as assistant professor. He completed his PhD in Population Studies from the International Institute for Population Sciences, Mumbai, and his master's in Geography from Amravati University at Amravati. Professor Bansud has published several research papers in the area of population aging, public health, and other health-related issues in national and international journals. Presently, he is among the principal investigators in the NFHS 6, funded by the Ministry of Health and Family Welfare, Government of India. NFHS is a nationwide survey covering all 28 states and 8 union territories, providing the estimates of the levels of fertility, infant and child mortality, and other indicators in all the 731 districts across the country. He was also involved in a number of leading research projects under the Government of India, including immunization coverage study in Maharashtra, lessons learned and way forward, coping mechanism during the COVID-19 pandemic in unorganized sector, a qualitative investigation in the Mumbai metropolitan, NFHS 4, baseline study of action for adolescent girls in the selected blocks of Chhatarpur district of Madhya Pradesh, use of verbal autopsy for assessing the causes of death in Amravati district, Population Envis Ministry of Environment, Forest, Government of India, and the BKPAI, Building Knowledge Base in the Population Aging in India. He has also written 5 modules of population studies for e-Pathshala for PG students as part of the UGC project under the National Mission on Education through ICT. Alongside his professorship, Dr. Bansud is actively involved in various administrative and leadership roles within the institution, including the Controller of Examination, Head at the Center for Distance and Online Education, and Associate Head at the Center for Aging Studies at IIPS Mumbai. Through his teaching, leadership, and research, Professor Bansud continues to make a significant impact in the field of population sciences and on the broader academic community at IIPS and beyond. Thank you.
Over to you, Dilip sir.
Okay, thank you, Divya. Thank you, Lily, for that introducing Professor Dhananjay and myself. So after that, very interesting panel discussion, which speaks about which covered most of the overarching issues related to aging policies. We now move on to various nitty-gritty of the things. So we have something like 12 papers lined up. So this is going to be a really packed session. Okay, so it covers various aspects like social security, gender issues, then tribal religiosity, financing of elderly care, indigenous health, okay, health of indigenous people who are elderly. So let us go to the presenters. Before that, I request the presenters to be very brief and stick to the time. Preferably, you can finish in 8 minutes so that we can have that extra 2 minutes for discussion. All the discussions will be in the end of the presentation. So to start with, I request our first speaker, Mr. Amir Ali, who is going to speak on oral health, which is a very, very important issue concerning each and every elderly. So, Amir, please go ahead.
Yes, sir. Yes, sir. Thank you, sir. Hello.
Yes. You can share your slides if available.
Yes, sir. Thank you very much, sir. Good morning, everyone. So today I am going to present a research topic, self-reported oral health and life satisfaction in elderly, and also examining the mediating role of social support. So here, so the oral health simply means the conditions of our teeth, gums, lower buccal mucosa, and lower palate and upper plate of our facial systems. So it is when the oral disease, whenever we show the statistical of oral conditions worldwide, as per WHO, there are 3.5 billion people are suffering from oral health issue worldwide, and oral issue not only to concentrate about among a certain age group, it is concentrate among the individuals of all age groups. Mainly, the oral health issues are concentrate among elderly persons. So the peoples or proportions of older peoples are increasing. The burdens of oral disease also increasing. So in this study, we mainly focused among the elderly age 60 and above because the oral disease are mainly concentrate among the elderly persons. So in this study,
Hello.
yes, sir, I am audible.
Yes, you are audible. Please go ahead. So now you are back to the first slide. Move your slide.
So the objective of our study examine the association between self-reported oral health problem and life satisfactions, and also assess the prevalence of self-reported oral health problem in India, and also assess the mediating role of social support. So methodology, so in this study, we use LASI data, which is comprising mainly focus on older adult age 60 and above, that comprising almost 28,192 respondents. So here the main key variables, key variables that I used in this study, outcome variable life satisfactions, which is derived from the five items in LASI, and exposure variable, main exposure variable. To access the oral health problems, LASI use the 7 items, like seven items of oral morbidities in last 12 months, painful teeth ulcer, and swelling, gum disease, tooth loss, and dental cavity. If the people who have this type of diseases, we are consider that the respondent have a oral health problems, otherwise not. The mediating variables. So in this study, we use mediating variables as a social support. So in LASI, social support are access through both through subjective support and objective support and utilization support that I use through the guidelines of WHO. So here, this is the conceptual framework that I use in this study. The oral health problems are the people who have oral health problems are negatively impact on their life satisfactions. The life satisfactions and oral health, the people who have oral health problem indirectly impact on their life satisfaction through social support. So this is the prevalence of oral problem in India. So the map. So the most of the south state of India are highly prevalence of oral health issues as compared to the others state. So in this study, we use structural equation model to understand the direct effect, indirect effect, and total effect. So before performing the structural equation model, we use we to understand the reliability and coefficient reliability. We use the So this is the path analysis, which is so that the 7 items are there, which is comprises oral health problems. This is the directly impact on life satisfactions. That coefficient minus 0.8 that indicate that the people who have oral health issues are negatively impact on life satisfactions. And whenever we add whenever we add the mediating effect, it is reduced by 21%. And through oral health problems, whenever we show it add the mediating effect, social support, it reduces almost 14% of 14% of life satisfactions that impact by oral health issues. So this is the result that I got from these some structural equation models. So direct effect oral health problem and statistical 0.67% are directly coefficient of impact on the life satisfactions. Almost 14.5% are impact on the life satisfactions, and indirectly effect almost coefficient 0.14 means almost 14.8% are impact on indirectly through the social support. discussion. So the people who have poor oral health problems, they are less less life satisfactions as compared to the people who have not got oral health problems. So if we so this is the conclusion, this study highlights the significant impact of oral health problem on life satisfaction among elderly and with social support mediating the relationship. The finding revealed that oral health problems directly impact on life satisfactions, and also whenever we add the social support, it almost reduce the 28%. Means the people who have oral health problems, if we are providing a good social support, they improving the life satisfaction or well-being among the elderly. Thank you.
Okay. Thank you, Amir Ali, for sticking to the time. Of course, you have brought out some very important issue, which is one of the mostly neglected things in India's healthcare system, oral health. Of course, you have tried to relate it with life satisfaction. I am sure people will be having many questions whether the association you found is regarding the nature of association that you showed here in the presentation. We will have the discussion in the end, so we'll keep it there. We move to the next presenter. Next presenter is Abhishek Anand. So he is working on gender dimension of aging alone. Okay, so loneliness is one of the main issues faced by the elderly. Let us hear what he has analyzed and his results. Okay, Abhishek, please go ahead.
Yes, sir. Thank you, sir. Thank you very much. I'm sharing my screen. I think my screen is visible.
Yes, you can.
Okay, perfect. So good morning, everyone. I am Abhishek, and I am here to present this topic, Gender Dimension of Aging Alone, Examining Health and Quality of Life Among Older Adults in India. So as we look at the headlines in this slide, a clear and urgent consensus that emerges is loneliness is no longer just a personal feeling. It has been redefined as the 21st century pandemic. And while our global health systems are designed to fight viral outbreaks, we are now facing a hidden killer. We can term it as a hidden killer that the World Health Organization has declared a global public health concern. And so what is aging alone? It is defined as the what is loneliness? Right. It is defined as the subjective feeling of disconnection from others. And it is associated with various negative health outcomes. That includes depression, cognitive decline, and increased mortality risk. And when it is coupled with low social capital, it is increasingly recognized as critical factor that influences well-being of older adults. And the older adults, they are particularly vulnerable to loneliness and social isolation due to multiple factors. Those are like living alone, the loss of family or friends, chronic health conditions, and hearing or other impairments. Now, conceptualization of aging alone. There are multiple studies in India or in foreign countries. They are focused on either loneliness or social capital and the association with health outcomes. But here we conceptualize living alone as a combination of loneliness and low social capital. Combining both gives us the variable aging alone. Those who feel loneliness and their low social capital is low can be said that they're aging alone. And why India? So the Indian context is like India is experiencing a major demographic transition, and the aging population due to aging population, rapid urbanization, youth migration. These all are current scenario of Indian population, Indian demographics. And around 6% of the older adults who are age 60 plus now live alone without family. And that leads to a greater risk of loneliness and isolation. Now coming to the gendered concept of gender vulnerability in aging alone. So compared to older persons living with a partner, those living alone tend to be lonelier, and experience greater functional loss. And with regard to income, particularly women living alone are more at risk of poverty. And the crucial aspects of aging alone is the gendered experience of loneliness and social isolation. In many cultures, including India, older women, especially widows, tend to be more vulnerable to social isolation and economic insecurity than men. And among older adults living alone, women also report less satisfaction with life, which can be attributed to their relative disadvantage in terms of health and socioeconomic status. So based on these background, we formulated our objective to explore aging alone and its association with various health outcomes and the quality of life among older adults, with a focus on gender-specific differences. And to fulfill this objective, we have used longitudinal aging study wave 1 data that focuses on individuals aged 45 above, and that covers health, economic, social well-being, and other living arrangements indicators. And for this study, we have included individuals aged 45 and above, and the final sample size was around 65,500 older adults. And the main outcome variables were physical health, mental health, and age-related disabilities. And within physical health, it was self-related health, chronic diseases, depression, cognitive impairment, ADL, and IADL. Here, ADL is the activity of daily living, problems in activities of daily living, and problems in instrumental activities of daily living. Now, coming to independent variables, we have used the primary independent variable was aging alone. That was a combination of social capital index and feeling of loneliness. And the quality of life was generated constructed using PCA, creating a composite index of 21 items across 6 domains: that general health, environmental satisfaction, physical health, psychological life satisfaction, and social relationships. And other covariates that included age, gender, residence, and other background characteristics. Now coming to results. So aging alone is more prevalent among women than men, with around 6.23% of women and around 3.8% of women experiencing loneliness and low social capital. Older adults with no education are more likely to age alone, particularly women. And employment is also associated with lower rates of aging alone. Now, poorer economic backgrounds are more likely to age alone, particularly women. And age alone and physical activity, we can also see as the frequency of physical activity reduces, the prevalence of aging alone increases significantly. Now, aging alone and ill treatment. Those who reported ill treatment, they have higher prevalence of aging alone. Now, health outcomes by aging alone and by gender. People aging alone have worse rated health, self-rated health compared to those who are not aging alone. And with disparity slightly larger for women in this data set. And the data also indicates that older adults aging alone are more likely to have multiple chronic diseases with the pattern evident for both men and women. And around 13.86% of men aging alone had cognitive impairment, while around 30%, around 29% of the women aging alone had cognitive impairment. Older adults aging alone are more likely to have cognitive impairment, with the disparity being more pronounced among women. And these graphs compare the quality of life indicators between the older adults who are aging alone versus those who are not aging alone. This is stratified by sex. And across all domains, general health, life satisfaction, physical, psychological, social, environmental, and other overall quality of life, older adults, we can clearly see in the graphs that older adults who are aging alone report consistently lower scores than their counterparts, regardless of the gender. However, the gap between those aging alone and not is generally wider among women than men, particularly in life satisfaction, physical, social quality of life. Notably, we can also see men aging alone fare better than women aging alone across most indicators. And interestingly, both aging alone groups reported better psychological quality of life than those not aging alone. That suggests potential resilience or coping mechanisms in solitary aging. Overall, we can see the data reflects a clear disadvantage for the older adults, those who are aging alone. Now, this is a graph of odds ratios. Aging, we can see clearly aging alone significantly increases the odds of depression, cognitive impairment, functional limitations, that ADL and ideal for both men and women. And the risk magnitude is generally higher in men across most outcomes, especially for depression and cognitive impairment. Now, coming to conclusion, the findings underscore the significant vulnerability of individuals aging alone, with the pronounced gender disparities that reflect that intersection of socio-cultural, economic, and demographic factors. And the prevalence of aging alone was higher among women. Older adults from lower socioeconomic backgrounds are more likely to age alone. We can also see the stark gender difference in aging alone prevalence highlights how structural inequalities and cultural expectations shape older adults' experiences. And women not only experience higher rates of aging alone, but also report worse physical and mental health outcomes. The aging alone adversely affects the quality of life, with women reporting lower quality of scores than men. And this aligns with existing research suggesting that women, due to their longer lifespans and higher likelihood of widowhood, often face prolonged periods of social and economic vulnerability as in older age. And the risk magnitude of poor health outcomes is higher in men who age alone, even though more women experience aging alone for poor health.
Okay.
Now coming to the final, sir, I will take this is the last slide, sir.
Okay.
The final conclusion that community-based program that promote social engagement that is really needed, such as senior centers, peer support groups, and intergenerational activities that can mitigate the risk of isolation. And also we can say that technology has the potential to elevate loneliness and enhance social capital. Thank you.
Thank you, Abhishek, for clearly illustrating the overall prevalence of aging alone is lesser in India, but the burden is higher. That is what I take from your presentation. Okay. We move to the next presentation, that is on disability. Okay, so we have Gajendra Gupta, who has a very interesting presentation, again based on LASI data. So, Gajendra, please go ahead. Are you there, Gajendra Gupta?
He's there, sir. He's in.
Okay. If he's not ready, we can call the next.
Gajendra Gupta? Yeah. He's on mute. Gajendra Gupta, can you start?
Okay.
Next is Eugene Paul.
Okay, so we can give him chance when he is back. But now we move to Eugene Gupta. Okay, sorry, Eugene Paul, who has done a very interesting work on the mapping the geography of care transitions. Okay, over to you, Eugene.
Yeah, good morning, everyone. I'm Eugene Paul. Today I'll be presenting my paper titled Mapping the Geography of Care Transitions, Spatial Inequalities in Elderly Care Deficits in India. Is my screen visible?
Oh yeah, it's visible. Yeah.
Yeah. Okay, so this study examines where elderly care deficits are concentrated in India, why some regions are more vulnerable than others, and what this tells us about the India's transitions from family-based to system-based care. Okay, so the background. India is undergoing rapid demographic aging driven by declining fertility and the rising life expectancy. So traditionally, elderly care in India has been family-based, relying heavily on co-residents as well as informal caregiving. But these systems are now increasingly under strain due to the smaller families, urbanization, migration, and changing social norms. And at the same time, the ADL and IADL limitations are rising, which calls for increasing care needs among older adults. While we know that care needs are rising, we know very little about like how is it distributed spatially, but and also the gap that is the gap that the study is trying to address. Okay, so the existing literature shows that elderly care is shaped by family structure and socioeconomic transition. Research also highlights that southern and western India are aging faster. So my key questions are: what is missing? Like, where are the care deficits concentrated, and why are some states more vulnerable? So this study has three objectives: to map spatial inequalities in elderly care deficits across Indian states, to identify individual level predictors of care deficit using LASI Wave 1 data, to propose a care transition framework that explains the regional patterns of unmet care among elderly. And the data source and methodology. So I used the LASI Wave 1 data taken the elderly aged 60 and above for the analysis as per the objective. In the spatial analysis approach, I used Moranci to test whether the care deficits are spatially clustered, LISA maps to identify the hotspots and cold spots. And for individual level analysis, I used logistic regression, where I measured care deficits as like ADL or IADL limitations minus whether the care was received or not. That's how I measured care deficit. So care deficit refers to a situation where an older person has functional care needs, but he or she does not receive assistance from any caregiver. Importantly, care deficit is not just a health outcome message; it is also kind of a social signal where it reflects. It's a transition point from where family-based care is no longer sufficient, but formal care systems have yet to fill that gap. This makes care deficit a powerful indicator of care system stress. So the analysis shows substantial interstate variation in elderly care deficit rates. Southern and western states are exhibiting higher care deficit prevalence, while the northern states show relatively lower care deficit rates. So in the spatial analysis results, the spatial analysis shows strong clustering of care deficits, indicating the pattern is like not random. High clusters or the hotspots are concentrated mainly in the southern and western states like Kerala, Tamil Nadu, etc. In contrast, the cold spots or the low clusters are found in the northern states. So this is one of the striking things that I found. Okay, so the individual level analysis, the results showed that household living arrangements and the socioeconomic status mattered far more than remittances received and migration of children and all. Living with spouse and children significantly reduced the odds of care deficit. Older adults with no schooling or who are in the poorer consumption quintiles are significantly more vulnerable to deficit of care. Interestingly, the migration status and remittances were not statistically significant, challenging the common assumption. Okay, moving on to the discussion part. So the thing is, elderly care deficits are spatially clustered but not randomly distributed. The care needs are rising rapidly due to aging, and the family-based caregiving is weakening. Higher care deficits are observed, as in the previous studies, in southern and western states, despite the higher development side, which indicates a mismatch between rising care needs and available support systems. Okay, family co-residence remains a key buffer against the unmet care needs. Shrinking family size and changing norms weaken the informal caregiving, while living with spouse and children significantly reduce the care deficits. And there are Indian studies that highlight that co-residence or family living arrangements are central to elderly well-being. And the regional patterns reflect care transitions. Advanced aging, smaller families, and higher female labor participation might be contributing to the family-based to the transitional care systems and later on to the system-dependent care. So care deficit mostly it emerges when family care erodes faster than the formal systems can fill the gap of this deficit. Similar transitions are also documented in global aging research. Now, this is where I propose the care transition framework to explain this pattern. So, while in traditional care stage, the elderly care is primarily provided within extended families. So, when the families join family living together with higher co-residence with children and kin ensures the availability of informal caregiving. So, care deficits remain low here. While we move on to the transitional care stage, family size shrinks due to fertility decline, urbanization, migration, women's labor force participation, nuclear households, etc. When the informal care weakens, formal long-term care systems remain underdeveloped. So this stage produces the care gap, which leads us to the system-based dependent or system-based care. So here the family care is partially. Okay, so here the family care is partially replaced by institutional, community-based or state-supported care, expansion of home-based care or palliative services, and social care infrastructure. Care deficits reduce once the system is able to reduce the care gap. So the policy implications, existing policies assume the continued family-based care given the current aging policies in India, so which are little bit unrealistic in highly like the developed or the high aging states. So there is a clear need for region-specific long-term care strategies like community-based care systems, home-based and neighborhood palliative care services like that in Kerala, and we should develop the geriatric workforce, like train healthcare workers to consider and give care more to the geriatric people. Geriatric care. High deficit states should be like the priority regions for this policy intervention, and to so way forward, we can build community-based long-term care system. Yes, sir.
Your last
And
slide.
Yeah.
Okay.
Yes, sir. So elder care deficits show a spatial clustering, like that's what I concluded. Socioeconomic status and household living arrangements are that is what affects the care deficits. In South India is entering entering from a transitional to a system dependent care phase, and we require more region specific and state supported care policy frameworks to reduce the care gaps. Thank you.
Okay, thank you, Eugene, for that. Your title, no, when I thought, no, I was thinking about the other care. You are basically referring to the care within the household, no? Informal care.
Yes.
Okay,
Yes.
so title was a bit confusing. I thought overall care deficits.
Okay.
Okay, we will discuss at the end. Thank you.
Okay, sir. Thank
So,
you.
next presenter is Jishu Ketan Patnaik, who is presenting his study related to social security in contemporary India. Is Jishnu around? Jisu. Jisu
Sir,
is not sitting among the panelists.
No, his name is put as HP, the person with HP.
Okay, thanks. Okay, Jisu, please go ahead.
We can see his video, but his audio is not audible.
Yeah, you are not audible.
Sir, we cannot hear you.
We are unable to hear you, Jisu. Maybe you can rejoin. We can give.
Sir, if Gajendra is ready, we can finish.
Yeah,
yes, sir, I'm ready. I had some issue with microphone. Can I present right now?
Okay. So Jisu, log out and log in again. Okay. You can present next. Okay, Gajendra, please go ahead.
Yes.
So Gajendra, you are on mute.
No. Hello. Hello.
Hello, yes.
Am I audible? Hello.
Yes, you are audible. Please
Okay,
share
okay,
the
sir.
screen.
Okay. Is my screen visible?
No.
Hello.
Yeah, earlier your screen was visible.
Okay, okay, okay. Hello.
Yes.
Yes, yes. Hello. I am Gajan Gupta, a research scholar from Delhi School of Economics, and my topic is rural-urban differences in functional disability and its associated factors among elderly people in India, evidence from LASI 2017-18. So, if you talk about the activities of daily living and instrumental activities of daily living, then these are becoming a growing health concern among the elderly in India. Around 15.92% of elderly and are suffering from ADL, and about 36.12% facing difficulties related to the IADL. And the study of rural urban differentials become very important to study because different because of the people have different lifestyle, access to health facilities, and social structure, education, and etc. And elderly population is in India is projected to surge from 100 millions in 2011 to 230 millions in 2036. And growing elderly population is must be included in the health policy, and we should try to make their life productive and functionally active. So objective of my study is to examine the rural urban differences in prevalence of ADL and IDL disabilities among older adults, and special variations in prevalence of ADL and IADL disabilities across different states of country, and also to examine the association of functional disabilities with various socioeconomic and demographic factors affecting it. So data and methods. Data source is LASI Wave 1 conducted in 2017 to 18. Respondents are included in this study are age 60 years and above. Sample size is 31,773, and the outcome variables are ADL and IADL disabilities. And explanatory variable are age group, sex, level of education, marital status, etc. And statistical analysis includes cross tabulation, descriptive analysis, and binary logistic regression. So here I have constructed the outcome variables. Here it is given ADL, which includes difficulty with wearing dresses, chappal, etc., walking across a room, bathing, eating, getting in or out of bed, and toilets, etc. And in ideal, it includes preparing hot meals, shopping for groceries, making telephone calls, taking medications, work around and around the house or garden, managing money and bills, and getting around or finding address in unfamiliar places. So the rural urban differentials. Here we can see that prevalence of ADL is 21.3% in rural areas, whereas in urban areas it is only 19.32%, and severe ADL is 3.11% in rural areas, whereas 2.88 in urban areas. Similarly, the IADL prevalence is 44.79% in rural areas, whereas in urban areas it is 36.63%, and severe IADL is 6.78% in rural areas, whereas 3.90 in urban areas. And here we can see the spatial differences in prevalence of ADL and ADL in rural and urban areas. And here we can see that states such as Gujarat, Maharashtra, MP, etc. had ADL prevalence higher than 25%. Similarly, we can see in urban areas, ADL is higher in these states, but very low in northeastern states and Rajasthan and Telangana, Andhra. So prevalence of IADL, here we can see the stark differences in Rajasthan, northeastern states. Here is low for both rural and urban IADL, whereas in states such as Tamil Nadu and Karnataka and in Jammu and Kashmir, the prevalence is quite greater than 45%. So here we can see the state-wise prevalence of rural and urban ADL. In rural ADL, West Bengal, Maharashtra, Goa has quite higher prevalence, greater than national average, that is 24.41%, and states such as Rajasthan, Nagaland has lower prevalence. In the same way, in urban ADL, Goa, Daman and Diu, Sikkim, these are the states with higher level of ADL, whereas in Manipur, Arunachal Pradesh, it is quite low. And here is state-wise prevalence of IADL in rural and urban. Here in rural section, we can see that Jammu Kashmir, Chandigarh, West Bengal, Tamil Nadu, these are the states with higher prevalence, whereas in urban areas, Karnataka, Jammu and Kashmir, Himachal, again, it is very high. And if you see the state-wise rural-urban differences in the prevalence of ADL, here we can see states such as Delhi, Maharashtra, Chandigarh. Here, rural prevalence of ADL is quite higher than the urban ADL. And in the blue color, we can see like Sikkim, Daman and Diu, Mizoram. Here, urban ADL is higher as compared to the rural. Similarly, if we study the state-wise rural-urban differences in prevalence of IADL, then IADL is quite higher in Chandigarh, Maharashtra, and West Bengal, whereas where rural ADL is IADL is quite higher. Whereas in Sikkim, Himachal Pradesh, Nagaland, urban IADL is higher. And here we can see the results of our binary logistic regression. Then in both ADL and IADL, prevalence is higher age group, that is above 80, is quite dominating. And in females, ADL and IADL is quite greater. And if you see the association of education, then people who are more educated has lower IADL when we compare to the not educated people. And the other aspect, we can see that if a person has health insurance, then he or she has a very low prevalence of ADL and IADL, whereas anybody is taking tobacco, then he suffers more ADL. And we can see the connection of the economic status of people. Here we can see the people who are more here if you see the self-related health, then we can see that if health of the person is good, sorry, this is a mistake here, then it has lower prevalence of ADL and IADL. If health of the person is not good, then person suffers more to ADL and IADL. Here we can see most of the conclusion of this PPT, and prevalence of ADL and IADL has limited varies both states and rural urban areas. We also see that elderly in higher age group 18 plus and female elderly require more care, as they are more likely to suffer from ADL and IADL. Reduced tobacco consumption and good self-reported health also is important, and better education, life insurance and coverage life insurance coverage appears to reduce the functional disability among the elderly. Thank you so much. This was my presentation.
Okay. Thank you very much for a very crisp presentation. You stick to the time. Okay. So we'll discuss later. We have the earlier presenter. Is Jisu around?
Yes, sir. By name HP. He's there.
HP. Okay, okay. Jisu, now you can present your analysis. You are not audible. Jisu, you are
I
not
think you have to
audible.
increase volume from your system, computer or laptop. You have to increase volume. No, still not audible. मेरा तो जा रहा है.
Divya, you can ask him to log out and then join again.
Yeah, I'll call.
Okay. So because of time, we are moving to the next presenter. Okay. You please inform him. So now we have another analysis relating to multi-morbidity using the LASI data. Okay. So let us welcome Reshma Santosh.
So we'll have a tea break, sir, 10 minutes. If
10
you are
minutes.
done with the discussion.
Okay, okay. So we can discuss, or what is the?
Yeah, discussion.
Okay, so
Let us combine. We'll have the combined discussions. Let us take one presentation, and afterwards we'll have the tea break.
okay. So let us. Is Reshma around? I'm not seeing her here, Reshma.
Sir, they are yet to join. Because of tea break, they have not joined. So
Okay, okay. So then shall we break for tea or we discuss now?
can finish the discussion, sir. By then,
That's okay.
Okay.
Finish, sir. Yeah, you can.
So let me give my thing regarding. So Amir Ali's paper is on oral health, okay, which is one of the most neglected, not only for the elderly but also for the general population. Okay, so some of the variables he has tried to relate it with the life satisfaction. Of course, it is related to life satisfaction. We don't disagree, but you have to adjust for other variables like whether they have some other illness or not. Okay, so all these things are. Then within the oral health problems also, you have to see long duration. That is those illness which last for longer duration and those which oral health problems which are of short duration. They have to be treated separately. Okay, so you can of course improve your analysis by including these two concepts rather than directly attributing to the life satisfaction. The Abhishek's analysis on gender dimensions in aging alone. Okay, so that is it was very clear cut, crisp also. But my question is nowadays now the institutionalization of elderly population is going on. So will you consider the institutionalized population, elderly population as living alone or not? So that you can throw some light. And as a researcher, now we also expect you to see why there is a gap. Okay, why there is a male-female gap? How much of that gap is getting reduced because of the declining age gap between male and female? Similarly, how much of it is because of the mortality gap? These two, because these things are very dynamic. Okay, so how it will affect? So some forecasting, things like that, you can always attempt it in future. Then the third presentation is on the spatial inequalities. Okay, so that I mentioned initially, I thought the title can be made more specific so that you are looking only at the informal care that is within the household. Okay, so some of the variables like family transition, these things you can try to bring it if it is available. Okay, so another aspects which you have to consider is, does every elderly require care? You can see a lot of elderly taking care of others in the household. Okay, so that also you can pick up. Even in LASI, you have some section which covers how much time you are giving for taking care of others. So when you when you consider care deficit means you have to take both. The care which they give is more than the care they receive. Okay, so that type of analysis will actually, if you are using the word care deficit means care they give minus care they received. So that is the actual deficit. And time use surveys are best for studying that. Okay, LASI also has information on that. You can, in future, you can also consider when you call deficit, you have to look at both sides, care they give as well as care they received. Okay. This disability paper, of course, you have found a difference in this IADL and ADL. Okay, so but overall, no, the different rural urban difference, which is the main focus of your analysis, is mostly restricted to IADL. But the most interesting thing that you brought out is there is wide state-wise differentials in rural urban differences. So in that context, no, a little more deeper you can see why you have to decompose why this difference and see what are the factors contributing to these differences, because there are a lot of publications already in the public domain on the rural urban differences in the same. So you have to take a step forward in arriving at the real differentials. Okay, so that is all what I have to say. Now I hand over to Professor Dhananjay for his comments.
Yeah.
Professor Dhananjay, yeah.
Yes. Yeah, good morning. Yeah, so 4 papers so far we have presented, and I could see that all the papers are very good, and all the papers has presented, almost all papers are based on the LASI data. The first one is by Mr. Amir Ali, and he talked about the self-reported oral health and life satisfaction. So Amir Ali, the LASI is giving self-reported information on oral health. What about, have you also seen whether they have also use the biomarkers to collect the information to examine their oral health? Have you considered that examination part? Yeah, if you are, you just look at that one. If it is not there, so you just consider even that whether the both things are similar or both the results are coming out a similar way, or the whatever the self-reported are there, that is a different thing. So that's one thing. And regarding the Abhishek's paper is very good. It's talking about the gender dimensions of aging alone, examining the health and quality of life. Abhishek, when you're talking about the aging alone or the elderly alone, so have you only considered the alone, those who are living alone, or those who are living with a spouse as well? Because living alone is a problem, but those who are living with spouse again is because both the elderlies are vulnerable. They need at least some kind of support, care and support from their other family members. So whether you consider both the dimensions, if it is so, because I missed some of your presentations, I don't know whether you're considered or not. But if you're not considered, so you can also consider that aspect as well. Otherwise, the overall your paper was very good. Regarding Eugene's paper, she's presented about the mapping, the geography of care using the LASI data, and her major part was life care deficit. Eugene, my just concern is when you're talking about the care deficit, and you said that the care deficit is high in states and low in northern states. So why such kind of clusterings are appearing in southern and northern states? Do you have any reasons for that? And if it is so, then you can just briefly tell us why such kind of clusterings are happening in northern and southern parts of the country based on this care deficit. And last paper is related to the urban and rural-urban differentials, as the similar comment that Dr. Dilip has already said, that these kind of papers are available in the country in most of the places. You can also Google and you can find out there are many papers related to rural-urban differentials in the functional disabilities, because the functional disabilities is very common, and at this 60 plus, everybody will have such kind of disabilities, functional disabilities. So only major issues here is urban and rural differentials, and you're just saying whether they have urban rural differentials is not going to solve your purpose, or rather than you just decompose the thing and just get the real differences, why such kind of differences are coming up. So I think this is all about from my side. So all the very best. Thank you. Philip, sir,
Sir, you're
you
on
are
mute.
muted.
Thank you, Professor Dhananjay. So we will have a short break. We will assemble at 11:40 a.m. Okay. And Jisu, your presentation will be. Can you hear us, Jisu? Oh, you are still not audible.
Ishu, can you just log out and rejoin? No,
Okay, we will reassemble at 11:40 a.m. Okay.
Yeah. Okay, sir.
Yeah. Have a short break. Okay. Thank you. I also thank the presenters. Be around. Okay.
Hello, hello, hello. Yes. Hello.
Yeah, we
Hello.
can hear you, sir, now. Yeah, we can hear
Okay.
you.
Thank you, sir. Madam, when I will start?
Just two, we have gone for tea break. 11:40.
Okay.
Once the chairperson arrives, we will start.
And Madam PPT, can you share from your side or I'll share?
No, you will share.
Okay.
Madam, you are hear me?
Sure, sir. You're good. We'll wait for the chairpersons. Once they come, we will check. It's
Hello.
fine. I can hear you.
Okay, madam.
Yeah, fine.
Hello. Hello. Hello.
Okay, welcome back. Yeah,
Yes.
Okay, Dr. Jisu, you are audible
Yeah.
now.
Sir, good morning. Good morning. Thank you.
Yes.
Thank you. Actually, I'm extremely sorry for technical glitch.
So
Sir,
you're
actually, yeah. Welcome to all participants and learned panelists and experts. So today, I'm going to give a presentation on an aging population and demographic shift, a sociological analysis of the problems of aged and the need for social security in contemporary India. Sir, actually, my study has three major objectives. First objective is to reflect on status of aged in Indian society, and second objective is to analyze problems of aged in Indian society, and third objective is very specific to examine and analyze various social security schemes and implementation related challenges.
Okay.
Actually, when I'm contextualizing aged population in the world, I found that aged population is increasing all over the world, and India is no exception to it. According to one UN estimate, in Japan, 29% of the people constitute aged population. In Italy, percentage of aged population is 24.6. In Portugal, aged population is 24.5, and in Germany, their population is 23%. And according to 2011 census, elderly population in our country constitute 8% of the total population, which was in the year 2001 their population was 5.9. Recently, UNFPA conducted one estimate, and according to the UNFPA estimate, which was published in the 2023, by 2050, 20% of the population of India will be aged. But interestingly, aged population, though they are constituting significant percentage of the total population of the country, aged population in India are more vulnerable and they are marginalized. Why they are vulnerable and marginalized? Because 40% of the elderly population in India are economically poor. Their socioeconomic status is poor, and they are from backward communities. So when 40% of the elderly population in India is socioeconomically poor, it is significantly affecting their health conditions. It is significantly affecting their life expectancy at birth. Actually, aged in Indian society, occupied, important position actually. As per 2011 census report, 68% of people in our country are staying and living in countryside, in rural areas. As against to this, only 32% of people are staying in urban India or staying in urban cities. But in countryside, particularly in rural India, the family system is joint family system, whereas urban India is dominated by nuclear family system. What I find actually through my sociological studies and analysis, in joint family system, elderly people occupy central position. The head of the institution of joint family is eldest male member. So eldest male member is the sole decision maker of the family in Indian society. and his decisions are binding and obligatory among all family members. But what is happening in contemporary India due to disintegration of family system from joint family to nuclear family, from changing occupational structure, or due to impact of industrialization, urbanization, and migration of people from rural areas to urban areas in search of employment, livelihood, providing good educational facilities to their children, or getting good standard of living, or providing good healthcare facilities. Elderly people actually experiencing multi-dimensional problems, like their problems relating to their status or the authority which they are enjoying in traditional families like joint families. They're experiencing health problems, they're experiencing adjustment problems, they're experiencing financial problems. So I found there are two major sociological trend which is basically now taking place in Indian society. One sociological trend is feminization of rural population, and this is because of increasing life expectancy in our country. According to recent report in India, the life expectancy among women is 73 years. So when the life expectancy of women is increasing in different states of our countries, now it is significantly affecting elderly population and aged population. Therefore, aged population become more feminized. Second important sociological trend which I found, it is basically concentration of aged population in rural areas in rural India. So therefore, another trend that is emerging slowly, that is ruralization of the aged population. But in Indian society, rural population are struggling with poverty, with malnutrition, with unemployment. And among the states in India, aged population is highest in the state of Kerala, where the aged population is lowest in Bihar. So in my study, basically I utilized the frameworks of conflict frameworks of symbolic interactionism and structural functional theory of Professor Talcott Parsons. Recently, I visited one or two villages in the state of Jharkhand, rural India, to understand the problems of the rural population and how they are getting various kind of facilities of government of India. So though I found that aged in India have conventionally enjoyed privileges within the framework of a social economy, where the needs of the old remained a moral responsibility of the whole family actually. But that is not the case in contemporary India, when there is a huge shift from joint family to nuclear family, or due to high migration from rural areas to urban India. So I examined some of the social security schemes of government, central government and different state governments. So some of the important schemes of government of India are Indira Gandhi National Old Age
So
Pension
Dr.
Scheme.
Ginsu, now you have 4 minutes.
Okay, sir, I'll finish. So it is a central government schemes actually, implemented by Minister of Rural Development, where, elderly population, above 60 years age and under BPL category, they're getting 200 per month. And similarly, government of Jharkhand is also implementing a social security, scheme, where elderly persons, above 60 years, and they are getting 1,000 per month, and they are getting direct, cash actually. It is a direct benefit transfer. And similarly, government of India is also implementing, uh, Atal Bio Abhyuday Yojana for the senior citizens. This is non-monetary assistance funding for senior citizen homes, daycare centers, and mobile, medical units. And similarly, now Government of India, is basically through Ministry of Health and Family Welfare, implementing Ayushman Bharat. So all citizens in our country above 70 years of age, irrespective of income or category, they can get health insurance cover up to 5 lakh for family per year, and maximum people, aged people in our country, they have registered for this scheme, and many people are also getting benefits. Similarly, national family benefit scheme, this is basically for BPL families. But what are the actually implementation related challenges while visiting to villages in the state of Jharkhand, where more than 40% people are multi-dimensional poor, and people are struggling with malnutrition, poverty. What I found that elderly people in those two villages are not facing loneliness problem. They are happy actually, but the problem is that they are not getting actually pension regularly every month. So this is a kind of administrative bottleneck or administrative failure actually. Maybe government is not taking proper step to identify the beneficiaries, or lack of active bank accounts where actually monitoring supervision is required. This basically demonstrating the discrepancies between the state policy on the higher level and implementation related gaps. So with this, I think I should finish my presentation because it's already time. So therefore, the time has come. We should think about seriously about the aged who were considered once upon a time as a resources for the whole society. Now they are considered as the burden actually, because of their significant percentage in population of our country actually.
Okay.
Thank you, sir. Thank you.
Okay, thank you, Dr. Jisu, for bringing a sociological perspective in today morning's discussion. Okay, so very important that feminization of as well as ruralization of the aging population. Of course. Okay, so we will discuss later.
Yeah.
Okay. Now we move to Reshma Santosh.
Sir, she is not joined, so we
Okay.
can continue. Ujjwal.
Now is Ujjwal around? So Ujjwal has a very interesting paper on understanding the economic strain on elderly population. That is a primary database. Okay, so he has
Okay,
done.
sir, it is visible?
Yes, yes. Please go ahead.
Okay, good morning, sir. My presentation is that morbidity knocked the door of economy and understanding the economic strain of elderly population in Bankura district in West Bengal. So actually, the aging is one of the important issue in the country because highest number of people have aging, but there is no economic facility. So highest number of people also death because of lack of delivery system, lack of public health, and also private facility. So because if we discuss about the out-of-pocket expenditure behavior, it is the one of the important issue, particularly of aging populations. And in rural area, people is more suffer because of the lack of money. And at the same time, highest number of people have the poverty issue. That means they have not accessibility or availability in the residence. So according to 2017 report for the NCD disease, so it is accounting 45% of people have not covered because of the high level of treatment cost, particularly for the private hospitals. At the same time, for the admission 35%, and there is and also careless and also important issue. So WHO also identify that if the individuals or particular peoples have surpassed at least 40% of family incapability to pay the treatment cost, then it's basically called the household catastrophic health expenditure. So this is the one of the important issue, particularly of the rural residents in the West Bengal. So if we look about the particular problem in our districts, so it is found that Bankura is one of the rural districts. It is basically the southern part, Purulia, Bankura, Mednipur. And there is no sufficient health facility. highest number of people have suffering the different type of diseases, and medical facility, particularly the conditions of this medical facility is very worse. Only one medical hospital is there, and there is the minor hospital also there, but there is no available doctors, there is no bed capacity, even most of the time they is closed. So that means most of the people covering their medical service to private hospitals, and this is the one of the important burdens in particularly rural district of Bankura. So that's why my first objective is that the study to aim to address the gap of identify the out-of-pocket expenditures, particularly for NCD disease, and to identify the economic training, particularly among the elderly people, what type of facility are getting and how much amount pay, both public and private hospital in the Bankura districts. So my study is basically for the primary survey. So according to 22 block also there, among the 22 blocks, I have only selected the 5 blocks, and among the each 5 blocks, 3 villages have been selected. The first select the block based on the percentage of aged populations. It is divided by 3 strata, high, medium, and low. And after the block have selected, and third stage basically have selected by the respondent, particularly for the systematic random sampling each and every household. So total sample size in my survey is 480. This is the basic sampling design. The each and every villages, the 32 respondent village have respondent covers. So that is practically have 96 each block. So now total is the 480. So obviously my main outcome variable is the out-of-pocket expenditures, and several independent variables I have also selected based on the earlier literature like age, sex, marital status, what is the social groups, and their economic condition, basically based on the principal component analysis. I have asked what is the household condition in their family, what is the income, what is the if household have a car or not, a table or not. Those are basically asking the NSSO report. And also I have discussed about the what type of food preference, because some of the literature also found that those people have covering or consume the non-vegetarians have the highest prevalence of the non-communicable disease. So obviously out of expenditure I have calculated the sum of the inpatient and outpatients. There's a less reimbursement. After that, I have also further classified of out-of-pocket expenditure based on the healthcare facility, both public and private. And if we discuss about the statistical analysis, so if the household have spent at least 10% of total consumptions of expenditure, so that is called the CHA, catastrophic health expenditure, which is done by the earlier study. And after the identify the catastrophic health expenditure, then I have run the logistic regression analysis to identify with the predicted probability what type of amount of spend to the particular of healthcare sectors. Now coming to the result sections, I have also identified the people have suffering the different type of morbidity. One is the no morbidity, single morbidity, and multimorbidity. So it is really interesting that the male have suffering the 73% of multimorbidity, while the female is 65%. So because of the rural male is more working, the hard working, particularly have agriculture dominance. So that's why prevalence is more higher. Similarly, aging pattern also increasing, particular non-communicable diseases among the aged groups. There is 65 to 75 year age groups, 88%. It is generally observation that widow and divorced people is highest prevalence of the non-communicable diseases, particularly multimorbidity. And same time, it is found that the health expense particularly have social groups. The 65% of scheduled caste and corresponding 66% of the scheduled type are suffering the non-communicable diseases. And while Kuntel also found that richest people is more suffer the non-communicable diseases compared to the poor, it may be the reporting problem. Now, the main found that the main out-of-pocket expenditures, both public and private hospitals. So it is found that those people aged 75 plus, that around 6,650 they have amount spent total for the public hospital, which is the equivalent of $79. While the private hospital, it is the more doubles, 8,920, particularly aged peoples. And obviously, out-of-pocket expenditure among the female is more higher as compared to the males. So that is the 11,383. And again, if we discuss about the oil status, because of the poorest, poorer, richest, so it is found that around the 10,000 have richest people have been paid the public hospital for their health cost, either for the medical or maybe the transports. Again, we will discuss about the particularly disease conditions of the out-of-pocket expenditures. It is also found that people suffering the heart diseases is highest number of pay. So that is the particular for richest groups around 45,000, 11 and 17. So this is more highest as compared to I think 4 times is higher among the poorest groups. And diabetes, cost of the diabetes is compared to lower and then the other disease. And cholesterol also significant have highest level of cost, both also poorest groups, that is the amount paid the total 6,000. So if we look the total mainly our health expenditure among the morbidity by the households, so
You
poorest
have 2 minutes. Okay, 2 minutes. Okay.
yes, yes, sir. So total 6,400 they have pay, and richest group only the 4,480. Again, the aged morbidity prevalence is out of pocket expenditures more higher among the aged groups, and also 50 to 54 age group is more amount of pay. Now, if we consider about the cutoff to pay health expenditure in public and private hospitals, so obviously the private hospitals is, I think, 4 times more higher amount of the pay as compared to public hospital for the treatment cost of the non-communicable disease. Again, we will discuss about the catastrophic health expenditure among the predicted probability. It was found that those people have aged the 75 and above, and they have also reduced the 82%, while the 45 to 54 only reduced at least 90% of the catastrophic health expenditure. So that means aged people have the higher level of cost, and they also payment higher amount both in public and private hospitals. And particularly poorest people is more vulnerable. So if we discuss of the discuss section, the pattern of health expenditure, one of the is more issue in particularly rural residents, and catastrophic health expenditure is the higher among the oldest age group as compared to the older adult. And study also demonstrated that the poor household are less able to pay the healthcare cost compared to the affluent counterpart, and who is the more burden in the society. And chronic diseases, particularly highest number of healthcare costs, heart disease, cancer, stroke. So that's why we have also stated that the morbidity knocked the door of economy, particularly of aged household, because poverty is the one of the important issue. So we discuss the conclusion. It is significant evidence of burden of morbidity among the elderly people in the household, and household expenditure is more higher in the particularly private due to cost of the treatments, cost of the medicines, and also transports. So that means it is, and also poverty, one of the key the burden of the society. There is no facility among the poorest household. So, but some limitations also with there in my study, because this study is based on the self-reported, and some of the chronic diseases people also recall bias or underestimate. So that's why it's not possible that to do causal effect analysis. But still, in this problem, comment need to the taking care, particularly healthcare cost, and reduce the particularly private hospitals. Thus, all the people, particularly poor vulnerable people, should be treatment very carefully, and also accessible facilities should be there. So this is my snapshot during the survey. I also collect the sample each and every blocker, and also measure the hypertensions each and every household. Those have aged 45 plus. So thank you, and this is my presentation.
Okay, thank you. Even though you are not, you can see your picture is in the end. Okay, thank you. Very nice presentation.
Thank you, sir. Thank you.
Yeah. So we now move on to Abhishek Raj. Okay, so he is working on happiness. His study, I think, is on happiness among elderly. So Abhishek, you can start.
Okay, sir, am I audible? Hello.
Yeah, you are audible.
Yes, yes, you're audible.
Good afternoon, everyone. My name is Abhishek Razak, and I'm from Research Scholar in IIPS, Mumbai. My topic of presentation is religiosity or wealth, what makes people aged 60 and above happy in India. So, introduction. As we all know, in India, older people number is expanding, and it is because of the few reasons like increase in the life expectancy and the declining in the fertility in India. Because of these reasons, we need to ensure their well-being and that is also considered an emerging critical concern for the public health, because aging is often accompanied by some physical, emotional, and socioeconomic factors. So, as I say, the happiness of the elderly is very important. Happiness is defined as the indicator of subjective well-being that is also recognized as a key measure of quality of life among the elderly. It is also a key component that the aging should be healthy, and happiness is also influenced by many other factors like economic factors, social factors, cultural and psychological factors. And religiosity is also defined as a social and objective experience that involve a superior being expressed through the practice of individuals affiliated with a religious organization who share beliefs, values, and doctrines. So, also, religiosity is also, impacting many other sphere of our life like mental health, life satisfaction, overall well-being. And if people is, religious, so it can help them to be, psychological comfort and help them in social bonding and a sense of purposeful life. And on the other hand, also we can see that if people have the wealth, that will help them in to get, some access to healthcare and to get material security and to get them a good social participation. Uh, Still, this area like wealth versus religion is still a debatable issue. So my research questions are like this factor, wealth or religiosity has a strong influence on happiness in later life. And on the basis of that, my objective is to examine the association between wealth, religiosity, and happiness among older adults in India. So my database says Web3 that was conducted in 2019, and the sample size was 4,359 older adults that were aged 60 and above, and my outcome variable is happiness, and where I have taken binary variable that is that I have defined as happy or less happy, and my explanatory variable is wealth and religiosity. For this, I have taken some control variable that is like age, sex, marital status, place of residence, caste, religion, and education. And my analysis are bivariate analysis. And to examine the association, I have used the logistic regression model. So these are my findings. So before relating happiness by wealth status and happiness by religiosity, I have done a chi-square test to assess the significance of difference in prevalence, where I have find that the chi-square test is more significant, that is 10.25 in wealth, and less significant in religion, that is 7.97. And both the tests are p-value is significant. So if we'll see those happiness by wealth, so those who have poorer wealth, they have happiness is like poorer 51.32. As the wealth is increasing, we can see the happiness is also increasing. If we see the richest people, is like his happiness is like 77.08%. So from this graph, it is clear that if wealth will increase, so happiness will also increase. In second graph, if we will see, so we will find that as the people who are attending the religious functions, as the number is increasing, the number of frequencies increasing, they are feeling more happy. Like if we see the people who are never attending religious function, their happiness is 52% almost, and those who are attending daily, their happiness is around 82%. So and thereafter I have used the methodology odd ratio. So in which for the wealth status, I have used reference category poorest. When we see the unadjusted one, so we will find that as compared to poorest, who are the richest one, they are 3.19 times more happier as compared to poorest one. And if we will adjust the values after taking those factors, control factors, so then we will find that those person who is the richest, their happiness percent is 2 point compared to poorest, their happiness percent is 2.21 times higher than the poorest one. In the case of attending religion function, religiosity, my reference category is never attended religious function, where if I'll consider unadjusted value, then I'll find that those who are attending daily function, if we compare them with never attended religious function, their happiness is 4.19 times more higher. If we adjust the value, then I'll find that as compared to never attended religious function, their happiness is 3.02 times higher. So as odd ratio are not comparable for two variable, so to compute the I have computed average marginal effect to compare both. Okay. So where it is seen that where I have also seen adjusted wall test that this variable is more important in determining happiness, and for to test the adjusted wall test, stat is higher for wealth, that is 8.71%, and for religiosity, that is 5.1%. So it shows that the wealth is more prevalent to making happy people as compared to religion. So my conclusion is that religiosity and wealth both make happy older adults, but the effect of relative effect of wealth is more higher as compared to the people who are attending religious functions. Thank you.
Thank you, Abhishek. You have tested a very interesting hypothesis. Very interesting. Okay, we'll discuss later.
Yes.
Thank you.
Thank you, sir.
So now we move on to Ankita Roy. So her presentation is on children as a source of old age security. So Ankit, you can.
तो साला पढ़ा नहीं, भूल जा रहा था उसमें.
इंटरेस्टिंग टॉपिक तो है अगर
Ankita, you can share your screen.
Yes, sir.
अरे इसमें लिटरेचर नहीं, वहाँ से भूल जा रहा हूँ. adjusted
कोई
test
बात
क्या
नहीं,
है.
अच्छा था मतलब इस तरह से में गड़बड़ कर दिया था एक बार के बाकी
हाँ वही तो, वो साला पढ़ा होता तो.
लेकिन बाकी ठीक है। चलो अंकिता का भी देख लो।
Abhishek, can you go on mute, please?
ए तुमको बोला था।
Abhishek Rajak, please go on mute.
Okay.
Okay.
Ankita, you can start.
Okay. So good morning, everyone. Myself Ankita Roy, and I'm presenting my topic: Are children a source of old age security? The role of parity in food insecurity among older adults in India. So the level of food insecurity reflective of the uh, household economic condition closely associated with the poor nutritional outcome. So in low and middle income countries such as India, children are often viewed as a old age security in economic aspect, and also offering the emotional support. So however, fertility is decline in India, so old age population continues rising. So understanding how parity affects old age security is crucial in Indian context. So this study aims to evaluate the association between the parity and food security among older adults age 60 and above in India. So I use the longitudinal aging study web 1 survey data, and my study population is 31,588 older adults age 60 and above. So
my outcome variable is food insecurity. The Food and Agriculture Organization has developed the index of food insecurity, where it's a food insecurity experience scale. In FIES, there are 8 questions, but in LASI only 4 are available, and these 4 are here. This 4 variable determine the level of food insecurity. That's mild, moderate, and severe. The mild is denote if the respondent did not eat enough food of his or her choice, and moderate is the if the respondent reduce the size of your meal or skipped meal because of don't have enough food in the household, and the severe is the if the respondent was hungry but did not eat because of there is no food at house. So my main explanatory variable is the children characteristics, it's number of children and having children or not. And covariates are age, sex, educational attainment, social group, religion, marital status, MPC quintile, place of residence, region, social participation, and working status. And statistical analysis techniques are descriptive statistics, bivariate analysis, and multivariable analysis like logistic regression. So this is the result section of my presentation. This is the food insecurity level in India. In India, almost 45.3% of the older adults is 60 and above have experiencing food insecurity. Among them, 36.7% are mild, and 2.1% are moderate, and almost 6% experiencing severe food insecurity. This is the state-wise prevalence. This is the state-wise prevalence of food insecurity among older adults in India. So almost 50% state are above national average and 50% are below national average. So the highest state is Arunachal Pradesh, and the lowest recorded in Himachal Pradesh. That's 9.5%. This is the food insecurity level by state-wise food insecurity level in India. So Madhya Pradesh recorded the highest severely food insecurity, that is 15.5%, and Manipur recorded the highest mild food insecurity, that is 88.4%. So this is the elderly food insecurity by child survival and co-residence status in India. So elderly people whose children are not alive or no children, among them 52.4% are experiencing food insecurity, whereas whose children are alive but not co-residing with them, they are experiencing 48.9%. That is slightly lower from the no children or not alive children. And similarly, there is a statistical significant difference in whom children are alive and co-residing. There's only 43.6%. That's relatively lower among both having not children or not co-residing with their parents. So this is the elderly food insecurity by number of children in India. So there is no significant difference in the declining or food insecurity level with increasing or decreasing number of child. It's a very moderate glide. So this is my regression analysis result, where we saw that the having children or not is a very significant predictor of food insecurity among the older adults, as in compared to elderly who don't have alive children or don't have children. Who have children, they have relatively less they are relatively less experiencing food insecurity in India, as in compared to not alive or no children. People whose children are alive and co-deciding, they are almost experiencing 7.4 percentage point lower probability of food insecurity, and whose children are alive and not co-deciding, they are almost 4.8 percentage point less experiencing food insecurity in India, and this marginal effect is slightly declining when I adjusted the model with various socioeconomic factors, but still it's very significant predictor of food insecurity in India. This is the role of number of alive children in food insecurity among older adults in India. So this is also this is significant predictor, but the effect is very marginal. This is 0.6 percentage point, and after adjusting also it's very small. This is the role of the number of co-residing children in the food insecurity among older adults. So this is not significant in unadjusted model. That is also it's very low marginal effect, that is 0.4 percentage point. And when I adjust the model, it's a significant predictor, but the impact is very less. So in conclusion, in India, having children or living with the children reduces the food insecurity among the older adults, but number of children, it's not that much significant in Indian context. Thank you.
Thank you. Very, very interesting. So what did you do with those without children? You excluded them or what?
I included them in not alive children.
Okay.
Either they don't have children or not alive children.
Okay, okay, fine. Thank you for clarifying. We'll discuss. Okay. Thank
Okay,
you.
sir. Thank you.
Now we move to Soumya Nani's Mahali. Okay. So, okay, Soumya.
Hello, sir. Sir,
Yeah,
my voice is audible
yeah, very much. Please go
and
ahead.
my PPT is visible.
Yeah, visible.
Okay, so shall I start, sir?
Yes.
Um, Good afternoon to everyone, respected chair, uh, panelist, dignitaries, and audience. This is me, Soumya Naini Mahali, from National Institute of Technology, Department of Humanities and Social Science, NIT Rourkela. So today I will be presenting on the topic, does aging matter? Determinants of government health expenditure in South Asian countries. This work is jointly worked by my PhD supervisor, Professor Jalandhar Pradhan, and my junior friend, Mr. Tapan Swami. So before begin with topic, so as we know, health expenditure is a crucial component in overall health system. So if we go particularly definition of health expenditure, the definition is given by World Health Organization, that is, health expenditure includes all expenditure for the provision of health service, family planning activities, nutrition activities, and emergency aid designated for health. So, understanding what drives health expenditure is essential for planning sustainable budget and strengthening the health system. So, this health expenditure is, we can say it is directly linked with Sustainable Development Goals 3, which emphasizes healthy lives and promoting well-being for all. So, according to World Bank 2024 report, global health expenditure has increased from 9.81 2019 to 10.35 in 2021. At the same vein, in South Asia, the health expenditure is increased from 2.98 percentage in 2019 to 3.27 percentage in 2021. So coming to the determinants part, what affect in health expenditure? So health expenditure is influenced by various factors. It affected by government policies, demographic changes, socio-economic factor, political factor, and so on. However, in South Asia, population aging emerging as an important topic. So as life expectancy increase and fertility rate declines, a key question arises, Do growing elderly population pressure government do spend more on healthcare? So, figure 1 and figure 2 shows the trends of domestic general government health expenditure and trends of population aging. Here we can say both health expenditure and population aging has increased across all the South Asian countries. So here our main objective is to analyze the impact of population aging on per capita government health expenditure in South Asian countries, considering some important crucial factor as control variable, that is population density, labor force, GDP per capita, unemployment and physician. So here is the data and methodology part. So here we have used some econometrics tools. Here we have considered a dependent variable is domestic general government health expenditure per capita, and independent variable is population age 65 above. And as we already mentioned, control variable is population density, labor force, GDP per capita, unemployment, and physician. All the data, all the secondary data has been collected from WDI, that is World Development Indicator. It is a part of World Bank. So here we have considered 8 South Asian countries, that is Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka. So here is my model specification. In my equation, all variables are converted into logarithmic form because of normality. LNGHE, GHE stand for government health expenditure, and POP stand for population aging, and POD stands for population density. LFT stands for labor force. LNGDP stand for GDP per capita, UT stand for unemployment, PHY stand for physician, and epsilon IT is stochastic error. IT, this is the panel analysis. I stand for cross section and T stands for time. Here we have considered time period from 2000 to 2022. So for the time constraint, here I have not considered some diagnostic check, that is multicollinearity check, cross-sectional dependency check, heteroscedastic check, etc. So if anyone asks me, then I can show later. So in my diagnostic check, it is clear that because it is a panel analysis, so here we have some autocorrelation and heteroscedasticity and cross-sectional dependency issue. Therefore, we have considered Driscoll-Craig standard error methods, because Driscoll-Craig standard error methods helps to deal this issue. So after running the regression, we have found that population aging has positive impact on health expenditure. In this same vein, we also found population density positively affect health expenditure. So if we go some literature support that which highlight that if population aging increases, so there is so government may allocate some money for their aging population, so that they can maintain a proper healthy good life. And if population density increase, so there is high chance so population density is related to cities, and if cities increase, there is high chance some pollution and noise pollution, air pollution, etc. So therefore, if pollution increase, there is high chance this environment situation may affect aging population health conditions. So therefore, government spend more, so government health expenditure may rise. So in our result, labor force, we found negative relationship with government health expenditure, but it is insignificant. So literature supports that if labor force decrease, then that tends to increase unemployment. And if unemployment rate increase, so there is high chance, not there is high chance, if unemployment rate increase. So if a population, if a people is unemployed, then they can spend a lot of money for their health. So therefore, so this literature supports our result, and GDP here our result shows GDP is positively affect health expenditure, and it is significant. And obviously, we calculate GDP, that is Y is equal to C plus I plus G plus XM. So government health expenditure if increase, then obviously GDP will increase. So as I already highlighted that how unemployment affects government health expenditure, our result supports that physician increase health expenditure, and it is significant. So if physician increase, number of doctors increase, research, medical research, scientist work will increase, then they require some money. So therefore, some health expenditure also increase. So so this is my discussion point, which I highlight my some literature which support my result. So, in today's session, in our morning discussion, our panelists discuss about the role of policy and role of government. So, they all are highlighted, yes, because in Asian countries, governments should care about aging population. So in conclusion, our results support that yes, population aging matter, government health expenditure. So therefore, government should care about it. So all these are my reference, and thank you so much.
Thank you, Samyani. So very, very, very short presentation, but very clear. But what is that LPOP variable?
Sir?
You have a variable by name LPOP. What is it?
Sir, I didn't understand your point. Can you repeat?
You have a variable by name. You are showing a slide. So LPOP. Next slide, slide number 9.
Sir, here LPOP, here LPOP means population aging, and LPOD means population density.
Okay. Population aging means proportion elderly.
Yes, sir. Sir, it is a yes, sir.
Okay, how many time period data you have analyzed?
Sir, here I have mentioned that I have collected data from 2000 to 2022, 23 periods.
Okay. Thank you for clarifying. Yeah. Very good.
Thank you so much, sir. Thank you, sir.
Yeah.
So, shall I stop my presentation?
Yeah. So
thank you so much, sir. Thank you.
Yeah, thank you. So we move on to next presenter, Venkat Raja Malla. Okay, who will be speaking on health of indigenous population. Okay.
Am I audible, sir?
Yes, you are.
Good afternoon, sir. Myself Venkat Raja. Sir, am I audible?
Yes.
Okay, sir. Good afternoon, sir. Myself Venkat Raja from IIPS Mumbai. Now I am going to present on health and aging among tribal or non-tribal older adults in India. And my co-authors are Raghunath Mandi and Professor Dhananjay Bansud, sir. Introduction, the ability to define the healthy aging as a maintaining and improving functional ability that allows older people to achieve meaningful goals such as independent mobility, self-care, decision making, and community participation. And if you see the Indian context, it highlights the significant disparities. While non-tribal older adults often benefited from better healthcare access and social economic conditions, and in the case of scheduled tribes, elders frequently face poverty, limited access, and geographical isolation. And according to 2022 World Population Prospectus, people aged 65 and above represented above 10% of the world population in 2022, and this proportion is projected to rise to around 16% by 2050. And if you see this table, non-tribals in India from the census of India 2011. Here it shows like General population 60 plus, it shows in India 8.6%, and it in Himachal Pradesh it was 10.2, and in Goa it was 11.2, Kerala it was 12.6, and Tamil Nadu it was 10.4. And if you see the percent of scheduled tribe population 60 plus, it was overall nationwide it was 6.9, and Himachal Pradesh it was 9.8, and Uttarakhand it was 9%, and Goa it was 9.7, and Kerala it was 9.2. And some of the states and UTs, namely Punjab, Chandigarh, Haryana, Delhi, Punjab, Puducherry, don't have any tribal population in the country. To study the demographic characteristics among the non-tribes, non-older adults in India. Second one, to understand the health status and lifestyle behavior among the tribal and non-tribal older adults in India. And data and methods. The present study were used from the LASI Wave 1, which give information on health, social and economical aspects of the older elderly age 45 years and above at the nationwide. And the LASI covered the sample size of 73,396 individuals among 45 years and above. However, our study was subject to age 60 years and above. Therefore, the sample size of the present study was compressed to 5,326 tribal and 26,547 for non-tribes. Age adult age 60 years and above across the country. And descriptive statistics were used to describe the characteristics of the older population regarding various socio-demography conditions and health and lifestyle behavior among the tribal or non-tribal population in India. Results table 1, socio-demographic characteristics among the tribals and non-tribals in India from LASI. LASI provides information on chronic and mobility conditions. Therefore, we identified healthy ages using 9 important chronic diseases. And if you see the overall results from the table, the older adults are more likely to live in rural areas, have lower education level, and belongs to low wealth quantile. And non-tribal older adults tend to have a higher level of education, greater retirement prevalence, and a more even wealth distribution. And despite having a lower social conditions, tribals are having higher work participation rate at the older age. It indicates a potential of economic necessity. Table 2, health characteristics among the tribals and non-tribals in India. This functional health refers to the individual physical capabilities to perform basic activities of daily living. Therefore, the information on whether older individuals need to assist with their daily living activities or instrumental activities of daily living are presented in this table. If you see the overall result, the older adults from the tribal communities are having a better predicted health, a lower prevalence of chronic conditions, few functional limitations, and have a supreme mental health compared to older adults from non-tribal communities. And in the case of non-tribe, older adults are facing higher health burdens, particularly in hypertension, diabetes, joint disorders, and multimorbidities. And in table 3, lifestyle behavior among the tribal or non-tribal in India. To capture the lifestyle behavior in which the elderly living, the frequency of lifestyle behavior and social engagement of an individual is measured with 7 dimensions. Each question has 7 respondents. And if you see the overall results from this table, the tribal older adults engage more in social visiting, religious events, and community meetings. And in case of non-tribes, older adults are more likely to participate in outdoor games and cultural performance. Alcohol cues and smoking are more prevalent among tribal older adults and compared to non-tribes. Conclusion and discussion. Tribes and non-tribes in India highlights the significant disparities in socioeconomic status, education, employment, health outcomes, and social participation. And the tribal older adults mostly prominently lives in rural areas and having with a low education level and having low low wealth distribution, which favors the lower wealth content. Despite this, there are challenges. Challenges. They're having low higher work participation rate, which indicates rely on continuing employment for their social security. And in case of non-tribal, older adults are more urbanized with better education and more equally distributed wealth categories, and with higher retirement prevalence, and suggested a greater financial stability. If you see the health wise, the tribal older adults reported better prevalent health and lower prevalence of chronic conditions, possibly due to lifestyle factors and community support system. However, the lifestyle behaviors such as higher alcohol consumption, alcohol use, and smoking are more prevalent. More prevalent among the tribes, and which could impact long-term health outcomes. Social participation differ from the differ with the tribe older adults more engaged in familiar and community activities, while non-tribal participants are more in recreation and cultural activities, and promoting a positive outlook to have a towards aging is important, encouraging healthier lifestyle in achieving successful aging. And lifestyle risk factors such as smoking, alcohol consumption are more prevalent among male, rural residents, individuals with no formal education, those engaged in employment, and those belongs to the poorest wealth quantiles. These are my references. Thank you.
Thank you, Venkata. So it was a little bit controversial, no? Your analysis shows that tribes are healthier than non-tribes, which is we'll discuss it. Okay. So now we move on to the next presentation on understanding multi-morbidity gap. Okay, so the presentation will be by Himanshu Jaiswal. Over to Himanshu. Himanshu, you are there?
Is the screen visible, sir?
Yes, it is visible.
So hello, good afternoon, everyone. My name is Himanshu Jaswal, and I am a PhD candidate at IAPS Mumbai. Today, I am here to present my research title, Understanding the Morbidity Gap for Multiple Long-Term Conditions in India, Roles of Modified Health Behavior and Socioeconomic and Demographic Factors. Today, I would like to talk about important health issues that affect millions of Indians, especially as people age, the burden of morbidity, and more importantly, the disparity in that burden. In a country like India, where rapid demographic and lifestyle transitions are taking place, understanding who bears the greatest burden of morbidity and why becomes a critical question for public health policy. As India continues to experience demographic shifts and lifestyle rising life expectancy.
Your slides are not moving. Change your slide.
Now it is moving.
Slide 0.
Make it slide slow, size show, and move it.
Sir. So now it is.
Not it. I think you just stop sharing and reshare. Do it quickly. Okay, now it's moving.
So as India continues to experience demographic shifts and rising life expectancy, we also see a growing burden of non-communicable disease, particularly among adults and older population. One of the most pressing concerns in this context is multiple long-term conditions. In India, rapid demographic and epidemiological transitions have led to rising burden of MLTCs. These trends poses serious social and economic implications as individuals age with multiple long-term conditions. With India's increasingly aging population and rapid economic growth has resulted in chronic disease becoming one of the most challenging public health concerns, accounting for 63% of all deaths, according to WHO. So this leads us to a fundamental questions. Why do some people suffer more? As researchers and policymakers, we are constantly faced with one pressing question. Why do people fall sick more often or live with illness longer than others, even within the same population? In India's context, this question becomes even more complex due to the interaction of age, lifestyle, and socioeconomic disparities. So the present study has used the data from the longitudinal aging study in India. However, for our analysis, we have considered individuals who were greater than 45 years of age, and the final sample for the study includes 60,643. Coming to the variable description, we have focused on 9 disease based on self-reported diagnosis of individual in the LASI survey. And this question was asked in the survey like, has any health professional ever diagnosed you with the following condition or disease? The dependent variable was combined into a trichotomous variable of morbidity status with categories 0 that is no morbidity, 1 that is single morbidity, 2 that is 2 or more than 2 plus morbidity. To guide our analysis, we adopted the Anderson Healthcare Utilization Framework, which consists of predisposing factors, enabling factors, and lifestyle factors. So based on the earlier question, the study has 3 objectives: to examine the prevalence and patterns of morbidity, to examine the effect of socioeconomic, demographic, and lifestyle factors on morbidity. Third is to examine the contribution of socioeconomic, demographic, and lifestyle factors to the gap. To begin with, I conducted the bivariate analysis and chi-square test to check the association between background characteristics and the dependent variable. Next, I applied the multinomial logistic regression model and guided by Anderson Healthcare Utilization Framework, I built 3 progressive models. Model 1 included predisposing factors. Model 2 added enabling factors. Model 3 added reinforcing or health behavior factors. Finally, I conducted the failure decomposition analysis to check the morbidity gap between men and women. So what did the data reveal? Now I will lead you to the result of the study. The prevalence of morbidity was found to be highest among female. And in terms of wealth status, the individuals belonging to the richest rent quintile have reported to be higher morbidity prevalence. Also in the age group, the individual belonging to higher age group reported a high prevalence of morbidity. In terms of BMI, the individual who are obese reported a higher prevalence of both morbidity as compared to the underweight people. Next, this is the slide. This slide shows the prevalence according to lifestyle and modified health behavior factors like physical activity, alcohol consumption, tobacco consumption, and ADL disability. It is evident that the individual who never engage in any physical activity have reported a higher prevalence of both morbidity as compared to those who frequently engage in a physical activity. And compared to the no ADL disability, those who suffer from severe ADL disability have reported a higher prevalence of both morbidity. Similarly, in the case of tobacco consumption. And next, coming to the result of multinomial regression model. 3 models were run for both single morbidity and multimorbidity. Model 1 shows that the relative ratio of single morbidity is 0.3 times more among female and 0.4 times more among female of multimorbidity. After including enabling factors to model 1, the relative risk ratio is 0.26 times more among female and that of multimorbidity is 0.18 times. However, in model 3, after including all the models in full models, the relative risk ratio is 0.13 times more among female and that of multimorbidity is insignificant. That is, sex become insignificant after adding any of the in model 3. This is the forest plot of the full model. That is forest plot of both model 3 for single morbidity and multimorbidity. And the slide concludes that the multimorbidity is shows the strong factors for age, sex, education and wealth, BMI, tobacco consumption, physical activity, and those who suffer from severe ADL disabilities were the strong predictors of multimorbidity. Coming to the result of the decomposition, we have conducted decomposition in no morbidity and single morbidity between male and female. And from this slide, it is evident that much of the contribution has been explained by the working status and marital status. Similarly, the case in no morbidity and 2+ morbidity, the largest contribution is explained by working status and marital status. So, coming to the key findings of this study, the prevalence of multimorbidity was found to be 18.76% in general. Women have reported a higher prevalence of both single and multimorbidity compared to men, particularly in later life. Multimorbidity was found to be highest among individuals with greater age, wealthier, highest education, living in urban, never worked, obese, severe ADL disability, and those who never engaged in physical activity. Multinomial regression revealed sex was a significant factor in earlier model, but lost significance for multimorbidity after adjusting for lifestyle and socioeconomic factors. Age, BMI, functional limitation, that is ADL and IADL, and physical inactivity were strong predictors of morbidity. Finally, decomposition analysis demonstrated that overwork was the most important factor, contributing more than 50% of the total gap in no morbidity versus single morbidity and multimorbidity. Before ending this presentation, the study has several limitations, like it cannot establish causality due to the cross-sectional nature of the data. However, the study left us with a future follow-up as LASI is designed as a longitudinal study. The self-reported condition might undermine the true population estimate. And lastly, the self-reported condition may suffer from recall bias or underreporting due to limited healthcare access. And yeah, that's all from my side. Now I am open to questions, comments, or suggestion or feedback.
Thank you, Himanshu. Very, very systematic analysis. You stick to the time, but you should have presented. Results are also very interesting. You should have presented a little more slowly. Okay. So very good.
Thank you, sir.
Okay. So only one comment I have regarding your analysis is that why you dragged in the Anderson model, because it is mostly relating to healthcare utilization. No? So you didn't touch anything. Your analysis mostly focused on this multimorbidity. Okay, so you are showing that in your slide, so that is why. Other was one on utilization. Okay, so if you are showing, you should try to integrate. I am sure you might have done it in your write-up. Okay.
Yes, sir, in full paper it is.
So that has to be there. And more importantly, multimorbidity is something that has been studied so much using LASI data. I haven't read all the papers, so I am not able to comment. I wish your paper has something additional. Okay. So now we are reaching our time, 1 o'clock. So let us discuss the papers. Okay. So let me start with the paper by Dr.
Shall I stop sharing?
Yeah, you can stop sharing. Okay, so you. So Dr. Jisu, his paper was on, he has brought in a new perspective, especially sociological analysis. Okay, so but it appeared more like a lecture. It was very nice listening to you. You would have some more empirical aspects would have been mentioned. Okay, so there is something called feminization of aging, ruralization of aging population. But data, if you see, the ruralization, it is not restricted to rural areas. If you look at the real data, such issues are more in urban areas than in rural areas. Okay, so that is what I feel. Now coming to the next study by Ujjwal Das. Okay, so Ujjwal Das is very, very in-depth field-based study on the catastrophic health spending in Bangura district in Orissa. So in this study, see, we give comment. We are not just criticizing your study. We are trying to give you some input so that you can think about it. And if you want to improve or know the limit, some of the limitation of the study. So everybody has to take it in that point. Overall, the study is excellent, very precise, the sampling design, everything is excellent. But you are calling it as a elderly, but the survey, you have included 45 plus population. So
Sir, this is actually the older adult.
okay, then you have to name it like that. So your age, your even title says like that. Okay, so the title, all those things. Okay, there. So that is something which you have to throughout the paper. You have looked at the older adults only, not elderly. The other thing is, which comes out from your analysis is that the public-private, the expenditure is not different. There is no big difference between expenditure in rural area, this public and private in that particular district. Okay, so why is it so? Why? What is lacking in public healthcare system? All those things you can throw some light when you expand your paper. Okay, so normally there has to be a gap, in your thing that gap is very low when compared to if you to compare the figures with NSS or other things. Okay, this issue may be related to your particular state, maybe public system may not be functioning efficiently. Okay, so some of your results also could be due to that.
Sir, basically the difference is not there because of the transport facilities is one of the important issue in the districts.
Yeah. So that all those things when you write your paper, you can highlight. Okay.
Yes, sir. Yes, sir.
Then the paper by Abhishek Rajak. Okay, so again, he has boldly compared which one is better, religion or wealth. Okay, so interesting. Results are very interesting, but only we also have to consider that you are using three variables. Okay, one is religion. So it has been from birth or it has a long-term effect. Similarly, you have wealth. Wealth also is like that, but your outcome variable that is based on very subjective and depends on the day of interview. Are you happy, less happy, not happy? That kind of. Okay, so overall, you are able to establish also the wealth. The relationship is more stronger in the case of wealth than in the case of religion. If I was there, I would have also extended it to see within every wealth quintile how it varies. Okay, so what you found, okay, within every wealth quintile how it varies. Okay, so religiosity. That also, if you can add to your analysis, it might improve your analysis. Then the paper by Ankita Roy on Are children a source of old age security? Overall, excellent analysis. You have used the FIES scale, but this one, FIES scale, according to the scale and what you presented, almost 90% of the elderly are having some sort of food insecurity. Okay, so that is very, figure seems to be very high, but of course, maybe that is the reality. Sometimes people may be having food to eat, but they may not be eating the right combination also, food. Okay, so that might also happen. Then still, I am not clear whether it is the number of children or whether it is the presence of a working adult in the household, which is, your results are very convincing, but that variable is not there, number of working adults in the household. So whether it is children or living with the children or whether the number of working adults in your household, which makes that difference in food security, that you can try to see. Okay, maybe the result will remain the same even after adjusting for that. But you have to see those things. We also had a very interesting paper by Soumya Nayani. Okay, so that is on government health expenditure in South Asian countries. So what you have, of course, you have clearly explored the relationship between government health expenditure. What determines the government health expenditure? From an aging point of view, you just have a variable called proportion of elderly or LPOP, that variable. Okay, so what I find is that lag variable, do you have that? That variable is missing when you do this type of modeling, So if you put some money this year, the effect will be, or if there is a policy change this year, the effect on expenditure will be after 2 or 3 years. So that variable was missing. You can also include that
Okay.
variable in your
Okay, sir.
analysis.
Thank you so much, sir, for your suggestion. I will keep it in my mind. And if I add this lag variable, then it will ultimately solve my another problem, that is endogeneity issue. So thank you so much, sir, for your suggestion.
Yeah, immediately you won't find if there is something changed, it will not be immediately reflected in the government health expenditure. That is what maybe you can keep it as your limitation. Okay.
Okay, sir. Thank you so much, sir.
Otherwise, very precise, very analysis. Okay. And the analysis by Venkat Rajamalla or between tribes and non-tribes. Okay, so you have brought out the variations, but what I feel is, why are the tribes really that much healthy? Because they are characterized by poverty, all those things, living in backward areas, but your analysis says the opposite of that. Okay, so some more, why is it so? Okay, that you have to explore in your analysis. Okay, there could be reasons others have done. Okay, there are papers. Why, when you just look at subjective things, why tribals are showing better health than non-tribals. Okay, so that aspect also you can consider in your analysis. Himanshu, I have already mentioned. So thank you. That is all from my side. I pass on to my co-chair, Professor Dhananjay.
Yeah, thank you, Dr.
Sharing his
Dilip,
views.
for chairing these sessions and giving the very critical comments. I'll just summarize the presentations. So first paper by Jishu has talked about an aging population and demographic shifts, and he discusses the demographic aging in India, the social problem faced by older adults, and the growing needs of social security systems. The second paper by Ujjwal Das, mainly he examines how illnesses among the elderly creates financial stress for household and affects the local economics. The second paper by Abhishek, he's talk about the religiosity, wealth, and happiness among older adults, and he investigates how religious involvement and economic status influence happiness among the Indians aged 60 plus using the Wave 3 datasets. I have one slightly concerns whether the way such Wave 3 datasets are available and if it is where, because I have not seen so far. So this is just a concern. The next paper by Ankita, she is mainly talking about the children as a source of old age security, and she assesses whether having more children reduces food insecurity among older adults in India using again same LASI datasets. The next paper by Ms. Soumya Naini, determinants of government health expenditure in South Asian, in South Asia. It's a very good paper, and she mainly analyzes how population aging influences the public health spending across the South Asian countries. The second by Venkat Raja, he's mainly talking about the health and aging among tribals and non-tribals. He compares health outcomes and aging expenses between these tribals and non-tribal elderly population in India. And lastly, by Himanshu, he mainly understanding the morbidity gap for multiple long-term conditions, and he explores how health behaviors, socioeconomic status, and demographic factors shape disparities in chronic illnesses. So overall, these studies highlights the multidimensional challenges of aging in India, emphasizing health inequalities, multimorbidity, gender and regional disparities, economic vulnerability, and the crucial roles of social support, family, and public policy. They underscore the need for inclusive social security, equitable healthcare access, and targeted interventions to improve the well-being of India's growing elderly population. So thank you all the participants and all the presenters for presenting a very good paper. And I hope that this will definitely add more to this conference. And also we are planning to have publish the conference proceedings. And if you are interested, you can submit your full paper once it is finalized. So thank you all. And the next session will start around 2 o'clock, Divya, because we have already delayed for 10-15 minutes.
Sir, we will start at 1:40 or 1:45 because it's still 1:10. 2
Yeah,
will
I
be
think
very.
it's slightly late. Anyways, we'll just keep 1:45
Shall we
something.
start at 1:45, sir?
Yeah. Okay. Over to you, Dr. Dilip. Thank you so much.
Yeah, thank you. So let us break for lunch and get back around 1:45, 1:50
Okay.
like that.
Thank you.
Okay.
1:45, sir. Okay.
Yeah.
Thank you. Shayoni Das, you need to join as panelist. I'm promoting you, you're declining. Please join. Can you hear me? Or please look into the chat. Can you answer in the chat box? Shayoni Das. Shayoni Das, please join as panelist. Do not decline. Can you hear me? Otherwise, you will not be able to present.
Good afternoon, everyone. Am I audible?
And wait for your turn. No issues.
Okay. Am I audible? Just checking the audio for
Yeah.
once. Okay.
Yeah. ಮೈಕ್ರೋವೇವ್ ಮೇಲ್ಗಡೆ
Shall we start? Hello. Divya,
Hi,
can we
sir.
start?
Good afternoon.
Yeah,
Yeah,
yeah.
I have
People are yet to join.
Raghunath going to introduce the chairpersons, and all the speakers are ready, sir. They are lined up.
Okay, yeah.
Over to you, Raghunath.
Thank you. So before formal starting of the session, I'd like to briefly introduce two of our chairpersons, starting with Professor Dhananjay. Professor Dhananjay is a professor at the Department of Public Health and Mortality Studies at IIPS. Prior joining to IIPS, he was working with Population Research Center at ISAC Bangalore. Professor Bansode's research interests include population aging, public health, large-scale survey research, maternal and child health, and well-being of elderly. Professor Bansod have publications across diverse issues in population in various national and international journals. Currently, he is one of the principal investigators of National Family Health Survey funded by the Ministry of Health and Family Welfare. Apart from the research endeavor, he is currently associated with various administrative responsibilities at IIPS, including the control of examination, department head at the Center for Distance and Online Education, and coordinator for IQAC. And Professor Bansod continued to make significant impact in the field of population sciences and on the broader academic community at IIPS and beyond. Now, our second chair is Professor T.R. Dilip. Dr. T.R. Dilip has nearly 20 years of experience in researching and global monitoring of maternal, child, and adolescent health in low and middle-income countries. Dr. Dilip worked as an associate professor at the Department of Family and Generations at IIPS. He has the experience of serving World Health Organization, Public Health Foundation of India, Center for Development Studies, Thiruvananthapuram, and Ministry of Health and Family Welfare. He has experience in implementing the WHO's global survey for monitoring and implementation of maternal death surveillance response global implementation of integrated management of childhood illness, global tobacco survey, and WHO steps. Dr. Dilip's ongoing research projects related to population and health related issues are funded by Ministry of Health and Family Welfare, ICMR, and World Cancer Research Fund. Now it's up to the chair. Thank you.
Yeah, good afternoon all. Yeah, now after the lunch, we'll starting our sessions, and in this session we have total 9 papers. Let me see whether all the presenters are available. Okay, yeah, I think that all the presenters are available. Let me just briefly talk about the session, and afterwards we'll start the session. The present session is themed socioeconomic and cultural diversity and features and papers that explores diverse dimensions of aging in India. The presentations address important issues such as changing family structure, the emergence of elderly-only households, and the impact of adult children's migration on social support system and overall well-being of older persons. This session also includes papers examining cognitive health, depressive symptoms, life satisfaction, and multidimensional well-being, and the recognition of older adults' contributions through reciprocity and solidarity from the life course perspectives. Each presenters will have minimum 10 minutes to present the paper, and we will hold a collective discussions at the end of the sessions. Now, with this brief remark, I will invite the presenters. First, let us call Mr. Saurabh Mandal, and he will be presenting on aging without care, the rise of elderly-only families in West Bengal, India, evidence from NFHS. So over to you, Mr. Saurabh.
Yes, sir. Sir, is my screen visible?
Saurabh.
Hello.
Yes, visible.
Is my screen visible? Is my screen visible, sir? Okay. Thank you, sir. My name is Saurabh Mandal. Today I will be presenting on the topic of aging without care, the rise of elderly-only families in West Bengal, evidence from NFHS. And in this presentation, I will cover introduction, data methods, findings, and conclusion. So, first of all, we all know that India is witnessing a rapid demographic transition with population aging emerging as a critical public health and social challenge. And by 2050, individuals aged 60 years and above are projected to constitute over 20% of the total population, with their numbers expected to surpass those of the children by 2046. And this shift, driven by increasing life expectancy and decline, has significant implications for healthcare system. And traditionally, extended family systems in India provide care and emotional support for older adults. However, due to urbanization, migration, and socio-cultural changes, contributed to the rise of single-person family and nuclear pair families, where the older adult lives alone or with one other person, often without adequate caregiving support. And despite the growing awareness of these two types of families, there is a critical research gap, and this study addressed the gap by examining trend in single-person family and nuclear families in West Bengal over nearly 3 decades, with a focus on the socioeconomic factors. And in case of data and methods, this study have utilized 5 rounds of National Family Health Survey data for West Bengal, and the outcome variable of this study is are the single person family, which consists only one person, and nuclear pair family consists of only couple, only consisting the couple nuclear pair. And the independent variable used in the study are age, education, caste, religion, marital status of household head, household wealth quintile.
What happened?
Saurabh.
Saurabh, I think he lost his
Maybe.
connection, it seems.
Yeah, network issue.
Yes, Saurabh.
Hello. Hello.
Yeah, please go ahead.
Sir, is my slide visible? Data and methods.
No.
Sir, is my slide visible?
Not it. Not it.
Sir, is it visible now?
It's coming now. I think something is coming. Yeah, it's visible now. Please go ahead.
Yes, sir. So, sir, I am telling that this study has utilized descriptive statistics, bivariate analysis, and multivariate logistic regression. And in case of findings, we can see these two lines are showing two trends of single person family and nuclear pair family. The blue line denotes the single person family, and the other color showing the from NFHS 1 to NFHS 5. And in the single person family by age of the household head, we can see that from NFHS 1 to NFHS 5, the majority of the single person family consisting of the age of the person are between 30 to 60 years and more than 60 years. And in case of single person family by marital status, we can see that majority of the single person belongs to either widow, divorce, or separated, and followed by currently married. And this trend is from NFHS 1 to NFHS 5, the similar trend is there. And when we look at the trends of single person families from NFHS 1 to NFHS 5 across the gender, that the female are more majorly aged 30 to 60 and more than 60 years and belong to either divorced or separated, whereas the male in the similar age category are majorly currently married. So there is a clear gap between the gender. Like females are majorly widowed in single person family, whereas males are majorly currently married. And in case of nuclear pair family, by age of the member, we can see that from NFHS 1 to NFHS 5, the age of the members of the nuclear pair are gradually increasing. From NFHS 1 to NFHS 5, this proportion of more than 60 years and 30 to 60 years, these two proportion has increased compared to less than 30 years. And in case of conclusion, we can say that the findings reveal a demographic shift towards an aging population increasingly concentrated in single person family and nuclear pair family, particularly among women who are disproportionately widowed or living alone. And in case of absence of caregivers, leaves many elderly individuals vulnerable to social isolation, economic hardship, and neglect. And addressing these challenges requires strengthening social security system, expanding community-based care services, and implementing gender-sensitive policies to ensure that older adults receive both financial and emotional support. And as India approaches rapidly in aging future, understanding how evolving family structure can affect the well-being of elderly is crucial for developing comprehensive policies that promote healthy and dignified aging. Thank you. Sir, you are on mute.
Thanks, Saurabh. So now we have the second presentation by Sadanand Karun. The discussion will be at the end. So Saurabh, be online. Sadanand, over to you.
Okay, sir.
Good afternoon, everyone. My name is Sadanand Karun, and first of all, I would like to thank the conference organizers for giving me an opportunity to present my work and I am very happy to present my work on the topic educational gradient in cognitive health among older adults in India, insights from LASI. So before moving ahead, it is very crucial to understand what does cognitive health means. So cognitive health is broadly a part of brain health. If we see the brain health, then it can be divided into 5 major domains. The first one is motor domain, which is related to controlling the body movement and maintaining the balance. The second domain is sensory function, which is related to seeing, hearing, tasting, smelling. And third domain is tactile domain, which is related to touch, pressure, pain, and temperature. And fourth domain is emotional domain, which is related to the interpreting, responding, and emotions. And the fifth domain is cognitive health domain of brain, which is related to thinking, learning, and remembering. If we talk specifically about cognitive health, then cognitive health is a is a part of brain function which is related to thinking, which is related to processing information, reasoning, which is related to solving problems, learning, which is related to acquire knowledge, language, which is related to comprehending and express ourselves, visual spatial functioning, which is related to understanding visual info, concentration, which is related to sustain mental efforts, and attention, which is related to focus on the task. If we talk about cognitive health in the specific context of population aging, then we can say that population aging is a global phenomenon with varying effects among high and low and middle income countries. If we talk about low and middle income countries, then low and middle income countries suffer more from the downside of aging because of two aspects. First, there is a rising burden of age-related chronic disease, multimorbidity, depression, and functional limitation. And second, in low and middle income countries, the health system is strained due to underdeveloped primary and long-term care facilities. Among several health related issues which are related to aging, cognitive health or cognitive decline is a major challenge. Cognitive decline causes dementia, which in turn further worsens cognitive health. And if we talk about the global estimates, then as per WHO, there are 57 million people worldwide living with dementia in 2021, out of which 60% were living in low and middle income countries. On the other hand, if we talk about education, then older adults in low and middle income countries possess low level of education. So the context where older adults are largely illiterate and suffer more from poor cognitive health, present study has a specific objective to assess the association between education and cognitive health among older adults aged 45 and above in India. Data and methodology. I have obtained data from LASI Wave 1. The data related to 57,794 older adults were extracted from LASI. My outcome variable was cognitive health, which was assessed through 5 cognitive health domain, that is memory, orientation, arithmetic function, executive function, and object naming. So in LASI, a set of questions were asked related to each of these 5 cognitive health domains, and if respondent answer correctly, then a score of 1 was given, and if they responded incorrectly, then a score of 0 was assigned. After summing all the responses, the cognitive health score ranged from 0 to 43, where a higher cognitive health score indicates better cognitive health and a lower score indicates poorer cognitive health. The key explanatory variable in this study was education, which was measured through years of schooling, and we have a set of control variables that are related to demographic factors, socioeconomic factors, health-related factors. In statistical analysis, we first performed bivariate statistics, which was followed by multiple linear regression analysis. Talking about findings, if we see the education level, then among older adults, more than half, that is 50.7% older adults age 45 and plus above in India were uneducated, means they had no schooling, and only 49.3% were educated. If we talk about the education by years of schooling, then there were 50.7% with 0 years of schooling, 17.7% with 1 to 5 years of schooling, and 21.1% with 6 to 10 years of schooling, and only 10.5% of older adults age 45 and above were having above 10 years of schooling. If we see the cognitive health variation by education, then we can clearly see that the education cognitive health vary significantly by education. For instance, Among uneducated group, the mean cognitive health score was 20.5, whereas it was 28.2 among educated older adults. If we see the variation by years of schooling, then we can see that the cognitive health improves significantly as we move from higher years of schooling. For example, older adults with 0 years of education had 20.5 points mean cognitive health score, whereas it increased by around 5 points and reached 25.3 points for older adults with 1 to 5 years of schooling. And older adults with 6 to 10 years of schooling, it was 28.9 years. And those who had above 10 years of schooling, the mean cognitive health score was 31.6 years. So this graph specifically show a kind of gradient in educational gradient in cognitive health, which needs to be further investigated through various socioeconomic characteristics. In this graph specifically assess the cognitive health by education across socioeconomic characteristics, and we can see that in each socioeconomic characteristics such as age group, sex, marital status, working status, caste group, religion, wealth status, place of residence, region, frequent physical activity, BMI, chronic condition, social participation, and tobacco or alcohol consumption. In each of these background characteristics, there is a kind of educational gradient in cognitive health, which systematically increases as the years of schooling increases. Now, is my slide moving? Hello.
No, you are stuck somewhere there. You zoom. No, afterwards it's not going.
Full slide is not seen.
Yes, I am exiting it, but it is not getting
You click
in.
somewhere outside.
You're not using, you're using some other, not PowerPoint.
I was using PowerPoint, but when I zoomed it, then it became stuck. Is it visible now?
Yes, yes.
Yes, so in this figure, we can see that there is a kind of education gradient across socioeconomic characteristics. Then we to further assess the association between education and cognitive health, I have run the regression models. There were 4 regression models run. In model 1, that is unadjusted model, in which only years of schooling and cognitive health was included. In model 2, we have added demographic factors. In model 3, we have added socioeconomic factors along with demographic factor. And model 4 is the fully adjusted model, which have included demographic, socioeconomic, and health characteristics to assess the association between cognitive health and education. So from model 1, we can see that as the years of schooling increases, the cognitive health, the regression coefficient for cognitive health also increases significantly. And compared to 0 years of schooling, those who had above 10 years of schooling, this is significantly higher. And even after adjusting for demographic characteristics, the same kind of education gradient it was visible. And in model 4, which is fully adjusted model, the education gradient can be clearly seen that with reference to 0 years of schooling, the beta coefficient for cognitive health increases significantly as we move from 0 years of schooling to 1 to 5 years of schooling, 6 to 10 years of schooling, and finally above 10 years of schooling. So on the basis of this regression analysis, we can say that there is a kind of education gradient. There is a clear education gradient in cognitive health among older adults in India. And to achieve better cognitive health in later life, there is a need to introduce lifelong learning opportunities for older adults in India. Thank you.
Thank you, Sadanand, for completing your paper on time. So now we have next paper by Anil Kumar Pal. and he will be talking about the socioeconomic determinants of social support among elderly populations. So over to you, Anil.
Okay, sir. Thank you.
Anil Kumar.
Yes, sir.
Okay.
Wait, sir. Wait a minute. So, good afternoon to all. My name is Anil Kumar Pal. Today, I am discuss about socioeconomic determinants of social support among the elderly, a comparative study of old age homes and family settings. So, move to introduction. Wait. Yes, India is expressing a rapid demographic shift with the rising proportion of the elderly. Traditionally, the family has been primary source of economic and emotional security. And however, urbanization, migration, and shrinking household size are weakening this traditional support. And traditional, the family has been the primary source of social, economic, emotional support. However, this system is weakening due to urbanization, migration of working age children, as the rise of nuclear family structure. Old age homes are growing alternative, rising urgent questions about disparity in well-being. Social support is a critical and consistent predictor of mental and physical health in later life. Now move to research gap and research objective. So research gap is in this study, India aging population is the rising rapidly while traditional family support system are weakening because of migration, urbanization, and growth of nuclear household. Old age homes are becoming more common as alternative living arrangement at little is known about how they compare to family settings in terms of social support for the elderly. Social support play a key role of emotional well-being, mental health, functional status of overall quality of life in later years. Evidence on social support among the elderly in the Uttar Pradesh is limited, creating a clear need for focused research in these settings. So there are two objectives in this study of this study. So first is to examine the social support among the elderly in old age homes versus family setting, to determine the social demographic and economic factor influencing of social support. So move to methods, data and methods. So data source and research design. Data source is primary data source. Research design cross-sectional cross-sectional study. A study area is Varanasi and Mirzapur districts of Uttar Pradesh. Why Varanasi and Mirzapur? Represent urban and semi-urban part of eastern Uttar Pradesh. High concentration of old age homes in Varanasi rather than in other districts of Uttar Pradesh. Mirzapur provides rural contrast for family settings. Districts show the strong migration flow and the changing family structure. Elderly dependency ratio are relatively high. Sample size is 364. Age 60 years and above were selected using random sampling. 182 respondents from family settings, 182 respondents from registered old age homes. Inclusion criteria is 60 years and above, residing for at least 6 months and able to provide informed consent. So this is stuck now. Hello. Yes. So this is a statistical method I have used. This model was chosen because order logistic regression. This model was chosen the dependent variable social support is ordinal, low, medium, and high. So this is step right now. Not.
Anil,
Yes,
go
sir.
ahead.
Not a slide move forward. This is right.
Is there any problem?
Sir, stuck my slide.
Your slide is stuck.
Yes, sir.
Close and restart.
Yes, sir. Wait.
Okay, reshare.
Yes, sir. Yes, sir. Data analysis, data collection. A structured interview schedule was used to collect data on socio-demographic economic status. For social support, social support scale modified Duke UNC functional social support questionnaire, assess emotional, tangible, affectionate support. So we have used bivariate analysis, chi-square tests were used to examine the association between socioeconomic variables and social support category. Multivariate analysis, because of ordinary logistic regression was used to identify independent predictors of life satisfaction, controlling for other predictors. So move to forward for result. This graph shows the distribution of social demographic profile among the elderly, and this graph shows the economic profile of the elderly, and this graph shows the financial support and living condition of the elderly. So this graph shows the prevalence of social support by setting. uh, uh, Social support, this first graph shows that the total social support of the elderly, low is 32.4 and medium 20.1% and high 47%, so 47.5%. And second graph is shows that the family versus old age homes. A low social support in family setting 17.6% and old age home 47.3%. A medium in family setting 19.2% and old age homes 20.9%. And high is the in family setting 63% to 2% and old age homes in 31.9%. So this is order logistic regression results. The elderly living in old age homes had lower social support than those in family settings. Widow individuals reported high social support compared to those never married. Those with no employment had significant lower social support than the family formally employment individual. No other variable in the adjusted model is statistically significant. So move to key findings of this study. The elderly living in family settings reported much higher level of social support than those in old age homes. Nearly half of the elderly in old age homes experienced low social support, while most in the family settings experienced a high support. Residing in the old age homes, independency ratio, the odds of receiving higher social support even after adjusting for social economic factors. Widowed elderly were more likely to receive higher social support compared to those who never married. Occupational history with the no employment has significant lower social support than those who never employed. Economic independence and asset ownership were linked with higher support. So higher support in unadjusted analysis, though this lost significance after adjustment. Residing away from one's home districts was associated with the lower social support at the descriptive levels, though this did not remain significant after adjustment. External financial dependence and the lack of employment were associated with the lower support. Age, gender, religion, caste, education, income level, or living condition did not significant predictor social support in the adjusted model. So conclusion and implication, policy implication. Conclusion: family setting provide much stronger social support than old age homes, and this gap persists even after controlling for social, economic, and the demographic factors. Living in old age homes reduce the likelihood of receiving high social support, showing that the institute cannot match the emotional and relational support offered by the family. Employment history is a major determinants with those engaged in the formal job. Self-employment agriculture work receiving for a higher support than those never employed. Economic independence and the self-reliance is strengthens social support while relying on the external financial assistance is linked to weaker support system. Widowhood elderly tend to receive more support than those who never married. Social support among the elderly is shaped more the structure and the life cost factors such as the housing arrangement, work history, and the marital status by than by background variables like caste, education, or income. So policy implication: strengthen family-based support system is to maintain the emotional bond that institutional care cannot replicate. Improve old age homes by adding structured activity, counseling, peer groups of trained psychological staff. Promote active aging through the livelihood option, part-time work, volunteer, and the skill building programs. Enhance social integration in old age homes by creating meaningful opportunity for the interaction and participation. Expanded community-based care model that the pursue interdependence and the emotional connection for older adults. So limitation of the study: the cross-sectional design does not allow conclusion about cause and effect. Social support was measured through self-reported data, which may introduce bias. The sample was limited to districts in Uttar Pradesh, which may reduce generability. Culture nuance of social support may not be fully captured by the standardized scale used. Thank you, sir.
Okay, thank you, Mr. Anil, for concluding your paper on time. So, and you have presented a good paper on social support among elderly as a comparative analysis of old age homes and the family settings. So that discussions will be at the end. So be online. And now we have the next presentation by Mr. Shubham Sharma, and he will be presenting on a bibliometric analysis and visualization on aging in place in the gerontological research. So Shubham, over to you.
Okay, sir. I hope the slides are visible.
Yes.
So very good afternoon to all. Myself Shubham Sharma, a research scholar from IIPS Mumbai. Today I will be presenting my research paper titled A Bibliometric Analysis and Visualization on Aging in Place in the Gerontological Research, one of the most important topic in the environmental gerontology. So moving ahead. So we all know that population aging is a global phenomena, and as per the UNFPA estimate, it is expected that 1 out of 5 will be elderly 60 plus by 2050. So it is going to create a huge challenge, being in terms of infrastructure, economic, social, care burden, and so on. So it will require the approach and services to fulfill the needs and requirements of the elderly. So one such approach or policy direction is the aging in place. It is a principle and orienting approach to fulfill the needs of the elderly. So basic premise of the concept or the approach is to support or help elderly to age in their own familiar environment, that is their home and community, to maintain their dignity, well-being, and quality of life. And that's why it is favored by the policymakers, healthcare provider, and even the older people themselves. And the WHO, in its framework of the age-friendly cities and communities, and the decade that we are now going, that is the decade of the healthy aging. Here also the United Nations has highlighted the importance of this approach for the well-being of the elderly. So here I have conducted the quantitative analysis using the bibliometric data from the Scopus database. Why Scopus? Because the Scopus is having the wider coverage, and also it includes the leading and regional journal as well. The sample size for this study is 1113, that is selected based on the Prisma framework. And these are some of the inclusion criteria for my study. The language which I have selected is the English language, and the document type which I have included is the peer-reviewed journal and the research paper. And the year which I have taken, that is from 2000 to 2025. to understand the recent development in this research area. And these are the search criteria which I have used using these Boolean operators. So the analysis which I have used, those are of two types. One is the trend and performance analysis that I have done using the RStudio BiblioSigning package in order to understand the research pattern and trend, and also to know the prolific aspect of the research. And the next is the science mapping using the Boss-Weaver software, which helps to understand the intellectual structure and the evolving research themes in the form of the bibliometric maps. So basically, both this analysis will help us to comprehensively understand the research landscape in this research topic. So these are the research questions which I am going to address through my this analysis. One is the what are the most prolific aspect of the research in the field of this aging in place research. What are the methodologies have been applied here? What are the research gaps and future research directions? And what are the key dimensions of this research area? And this is just an overview of the research result. So time span, as I've already talked about, and the sources is the is basically the journals. Here, the research on aging in place have been published on 375 different journals, which indicates why this topic is interdisciplinary and multidisciplinary in nature. Documents is 1,113 is the sample size. The annual growth rate is showing it is steady, and there is a growing interest among the researcher. And if you see the figure related to authorship, it indicates that it is large and collaborative. If you see the figure for the reference, it indicates that it is having a rich body of the existing knowledge. And even the average citation indicates that it is having good visibility and citation impact. So overall, I can say the research on this area is active, growing, and influential in nature. So this is the result from the trend analysis. Here you can see that earlier the research was the growth of research was study in nature. It was mostly focusing on the developed nation, and its focus particularly on the housing and house modification aspect. But after the 2010, we can see there is a growing interest among the researchers because of the global recognition of the concept of age-friendly cities and community, and wider acceptability also, especially in the developing nations as well. And after the post-COVID era, we see that there is a boost in the research in this area. And there is, after that, you can see the downward trend. Actually, the research, the data is of the early 2025, and it is not giving the complete picture of the year 2025. Hopefully, the research trend will increase over the period of time. This is the result from the performance analysis. So here you can see the in terms of publication, Aging and Society being the leading journal in this area. And in terms of indices, here you can see there are three indices: H index, G index, and M index. So H index measures the productivity and impact of a journal. G index is the weight of the most cited paper, and the M index is the year since last production. So based on this index, gerontologist being the leading journal in this research area. If you see the most influential work in this area is done by the New Zealand author Wiles et al., whose paper on this aging in place is regarded as the foundational paper, foundational work. So the most influential work in this area is done by the US author Greenfield. And if you see the country-wise production, USA having the most number of publication, being the most important contributor and producer, followed by the European nations and Asian nations as well. And you can also see the new research hubs are also emerging in the Asian nation and the African nations as well. So this is the country-wise collaboration map. Here also you can see USA being the dominant research hub, maintaining the bilateral collaboration with both the developing as well as the developed nations. So this is the network map. Here you can see the central one being the core concept, and the change in color from blue to yellow. You can see that there is a change of focus over the period of time. So earlier the research focus was on the housing and house modification aspect, but over the period of time it uh, more changes towards the psychological aspects of the aging in place, like quality of life, well-being, and new players are coming into picture, like China, India. So it suggests that research is growing in developing nations as well. So this is the cluster map. Here I have identified the four different cluster, and each cluster represent each dimension of the aging in place. Here you can see the first one is the housing and environment, is the physical dimension, which is focusing on the housing and house modification and the place attachment aspect. Next one is the social dimension. Social dimension includes the social networks, social support, and other social aspects as well. And third one is the psychological dimension, which include the quality of life and well-being aspects. And the last one, being the recent one, is the technological dimensions. So this is the summary of the result. Here, as I have already mentioned, that the research on this area is now expanding from the developed to developing nation, and uh, focusing on the methods. Earlier the focus was on the qualitative studies, but now it's shifting towards the quantitative and mixed method. And if we see the thematic evolution, the earlier the research focus was more on the physical dimension, but over the period of time it's now shifting towards the psychological and the technological dimensions. And there is a rising contribution on this area from the lower middle income countries as well. And these are the dimensions which I have already talked about. So overall, I can say that the research on this aging in place is rapidly expanding, and more work is needed in the developing nations, particularly incorporating the recent dimensions of the aging in place research. So I just want to take minutes to talk about why the concept of aging in place is important in India. So if we just look at the statistic, by 2050, we will be having around 20% elderly population, which means 1 out of 6 will be elderly population in India, and it is going to create a huge challenge in front of the government society. So if we see that the social structure of the India, which considered the caring for the elderly is considered as a cultural obligation, and sending the parents to the institution and old age home is considered as a stigma or taboo in the Indian society. Although in India is experiencing the urbanization, migration, and the modern concept of living is taking place from the uh, joint to nuclear family. But this promotion of this approach is very much important, as it will have both economic and the social relevance, and more sustainable than the institutionalization. Although the government of India have identified the importance of this approach in its policies and program, but such policies and programs are not grounded or localized in nature, and more awareness and education is required among the elderly in order to make this approach inclusive and sustainable model for the elderly worldwide. Yeah, thank you.
Yeah, thank you, Shubham, for concluding your paper on time and putting all the research papers related to aging in place together. So now we have next presentation by Vandita. I think Vandita is not available, so we'll just move on to the next presentation by Mr. Raghunath Mandi, and he will be presenting on challenging and dependency narrative, recognizing the hidden contribution of the elderly through reciprocity and solidarity. Over to you, Dr. Mr. Raghunath.
I hope my slides are visible. So good afternoon, everyone. I'm Raghunath. I'm a senior research fellow at International Institute for Population Sciences. So I'll be talking about challenging the dependency narrative, recognizing the hidden contribution of elderly through reciprocity and solidarity. This is some of the brief outlines. Uh, so I guess for the last 2 days we have been talking about more about the numbers and the projected figures of population aging in Indian context. So for me, what's most important, not only just the proportion, but in Indian context, the number is very important because the by 2050, the world population prospectus has, projected these figures around 350 millions, which is more than many of the developing and even the developed countries of the world. So, looking at the problem through two different lenses, if we could suggest, seeing it through demographic lenses, we can suggest that the recent demographic changes have reshaped the family dynamics in India, which may have tremendous implications on the family dynamics and even on the elderly well-being. And when we talked about population aging, it's predominantly portrayed as a challenge, if not an outright problem, not only in gerontological literatures but also in the media discourse. And the primary reasons to highlight this challenge is the generalization about the older people as they are not working, they're disproportionately consuming the health and social care, and therefore they're burden to the younger generation at a familial level and even at the broader level, they're consuming the national resources. So there is quite lesser discussion on the caring contribution that the elderly have within the family and society. So I tried to highlight based on my primary field survey. We tried to investigate the role and contribution of older persons in the family through a life course perspective. So I've used a mixed method research, applying both the quantitative research and qualitative research approach using various kinds of in-depth interviews, structured questionnaires, various key informed interviews, and few case studies. So the flowchart here shows the sampling frame. I have used the multi-stage stratified sampling frame to collect 400 respondents, elderly, those who are aged 60 years and above. Apart from this semi-structured interview schedule, I have used few key informed interviews and few in-depth interviews to highlight this scenario. So the question is, why West Bengal? Looking at the demographic scenario, West Bengal, if we see the TFR is current TFR of 2003 SRS report suggests that it's 1.3, which is way below the replacement level, which is supposed to be 2.1. And based on the census of 2011 population, if we could see the proportion of elderly is around 8.5%, which across both rural and urban areas, it's quite higher. And if we see the aging index, it's also quite higher in West Bengal. So these are some of the reasons to highlight the study in West Bengal, specifically to Hooghly district only. So briefly, I'll be talking about the summary or the key findings out of my field survey, out of my 400 samples. The donut chart here shows the current and preferred living arrangement pattern across the elderly in West Bengal. Around 20% of the elderly are there who are still staying alone or exclusively with their spouse. And the outer circle shows the preferred living arrangement pattern, so which suggests that some are still preferred living arrangement for the elderlies. The reasons, while we asked, most of them cited, their children are staying away and they have some kinds of family conflict, and nearly 6% suggest that they prefer to stay independent, and those are mostly in the urban areas. In terms of the work participation, if we see around 29% of elderly still engaged in any form of the workforce. The donut chart suggests the types or the category of workforce where the elderly are engaged. Based on the qualitative findings, we found that most of them, they need income and they want to support their families, and some of the elderly at the urban area, this reported that they want to remain engaged and in the family's farm. In terms of the different health status, around 75% reported that they have any form of chronic disease as highlighted, and joint pain is the most prominent across the different categories. However, in terms of the functional dependency, if we see, only 7% suggested that they are functionally dependent, although they have any form of chronic diseases, but still only 7% reported they are functionally dependent on their families. Now, talking about the caring contribution, they might have different fronts in terms of the economic support they provide, in terms of the instrumental support they provide, or any types of advisory roles they have. Overall, around 44% elderly have any form of economic support in terms of either maybe they provide in terms of daily living expenses, in medical expenses, education for the grandchild, household repair, or purchase of consumer durable, or even to organize any of the events within the households. And predominantly males are also, if you could see in the gender lens, males are still prominent in terms of economic support than females. However, in terms of the instrumental support in either providing custodial support, grandparenting, or supporting household costs, or even in managing accounts within the households, around 51% of the elderlies are overall supporting the household in terms of the instrumental support. However, here the gender lens is quite different from which we said in the last slide. Here around 64% of the females providing instrumental support than the males. In terms of the advisory roles they play across different lenses, we try to highlight in terms of either household decisions, in terms of marriage within the families, in terms of buying or selling of the property, or education of the grandchild, or organizing any of the social events within the households. Still, they have a higher proportion of elderly have opinions across these categories. So the following slide shows, the following forest plot shows the factors that are associated with the economic and instrumental support they provide within the household. So here in the first plot, it shows the economic support. What are the factors? So here the educational gradient, or having a better wealth quintile. Elderly, those who are in the better wealth quintile, are those who have any form of pension support from the government. They are having better, they can provide better economic or instrumental support. So the availability to provide economic and instrumental support are fundamentally shaped by their, socioeconomic positioning and their lifelong education attainment. In terms of the other socio-demographic characteristics, if we see, females are much higher. Females, or those who are residing in the urban area, have higher instrumental support in comparison to their counterparts. In terms of the advisory role they played within the household, in the preceding slide that we have talked about the types of advisory role. So here the current health status of the elderly, or even their wealth, or their education plays a major role. Those educated elderly, especially those who are having the higher education, have better advisory role within the household than their counterparts. So in order to understand the life course perspective of care and support scenario, or the solidarity within the household, we try to capture it through filial responsibility expectation scale. It is a scale refers to the types or level of expectation the older adults have regarding the duties and obligations from their offspring. So we use the Vignette approach to capture these dimensions using normative expectations based on this following set of situations that were asked to the elderly during the survey. So basically, the Vignette approach, it doesn't ask the question directly to the elderly, but they try to formulate in kind of a situation where the elderly has to respond based on a Likert scale. So the questions were prominently not the questions, the situations were mostly, do you think that the growing children should share their work and activities with their parents? Secondly, if the children lives nearby, they have grown up, they should visit their parents at least once in a week. Or sometimes, do you think, what is your opinion on growing children should live, whether they should live close to their parents, or they can, so that they can help each other? Or what is your opinion on whether older people should be dependent on their growing children for the material activities? Or do you think the parents are entitled to some returns for the sacrifice they have made for their children? So those are the kinds of questions that were being asked to capture these dimensions. And the odds ratio or the forest plot here shows, having a financial support from family, financial or the instrumental support from families, or having an advisory role within the families, have higher expectations in comparing to the other counterparts. Elderly, those who are staying with their married daughters, or even those who are currently the marital union and having better health status, were having higher expectations from their family members in comparison to the other counterparts. So in sum up the presentations, there is a need to recognize the care contribution of India, and it's really vital, especially presuming their dependency with increasing age. And there is a need to move beyond a burden-centric narrative to the reciprocal role of the elderly. So therefore, we need to reframe the social perception of aging, and there is need for responsive policies that valued the intergenerational solidarity and reciprocity of care. And definitely, there is a need for social messaging throughout especially at the community level, to spread the awareness regarding the intergenerational responsibility. These are some of the field photographs that I collected while collecting the data captured. With this, I'm concluding. Thank you.
Thank you, Raghunath, for concluding here
Concluding
for a long time. Yeah. Okay, so now we have one more presentation by Miss Sumedha, and she will be talking about the opportunities and challenges of mobility among the elderly population, evidence from Gurugram city, India. So Sumedha, over to you.
Good morning, everyone. So are my slides visible?
Yes, please go ahead.
Yes. So I'm Sumedha, and I'm a research scholar from Center for Study of Regional Development, Jawaharlal Nehru University. So I'll be presenting my topic titled Opportunities and Challenges of Mobility Among the Elderly Population, Evidence from Gurugram City, India. So this study basically examines how rapid urbanization transforms how rapid urbanization and has transformed the everyday mobility experiences of elderly residents in one of India's fastest growing cities. Yes. So India is experiencing a rapid demographic shift, as it has been discussed that elderly population is projected to reach about 319 million by 2050, as according to UNFPA estimates. And this demographic transition is occurring simultaneously with rapid urbanization. So while this transformation has generated economic growth, it has also produced urban spaces that are poorly aligned with the mobility needs of elderlies. So mobility plays a central role in elderly well-being. It determines access to healthcare, social networks, markets, and public services. However, in cities like Gurugram, mobility planning has largely prioritized vehicular flow, speed, and efficiency, often neglecting the everyday mobility needs of the elderly. So, start with this background. The study basically focuses on these are the research objectives of the study. What are the primary mobility challenges faced by the elderly residents in Gurugram? How do socioeconomic factors influence elderly mobility patterns? And what opportunities exist for improving elderly mobility through infrastructure, technology, and policy interventions? And what lessons can be drawn for other rapidly urbanizing Indian cities? So, literatures on elderly mobility emphasize that mobility outcomes emerge from interaction of three elements. These are the built environment, the individual capability, and the institutional support. And frameworks such as WHO's age-friendly city initiatives highlight transportation and the outdoor spaces as the key domains of elderly well-being. And evidences from developed countries show that walkable neighborhoods, accessible public transport, and safe street design are associated with higher level of independence, better physical health, and reduced social isolation among the elderlies. In Indian context, research identifies structural barriers to elderly mobility. These include poor pedestrian infrastructure, overcrowded and inaccessible public transport, traffic safety risks, and heavy dependence on family members. Although National Policy on Senior Citizens 2011, it recognizes mobility as a basic right, but its implementation remains fragmented and uneven. And starting with the research design, the study employs a mixed method approach combining qualitative, quantitative techniques. Study area Gurugram. Gurugram presents a case of splintering urbanism where high-end mobility infrastructure coexists with the uneven access. And approximately 8% of Gurugram's population is ages 60 and above. And while digital and app-based mobility are expanding in the city, but significant proportion of elderly lack digital literacy required to access them independently. So for the sample selection, a stratified random sampling design was used to ensure representativeness. Respondents were stratified by 5-year age groups, by residential types, including gated communities, independent housing, and the government colonies, and according to the gender. Within each stratum, the households were randomly selected, and one elderly respondent was chosen per household. In total, 400 elderly were surveyed. And data collection was concluded through schedule, interviews, direct field observations, and quantitative data analyzed through SPSS, and ethical protocols were strictly followed. So these are the general characteristics of the elderlies. The findings from the field show that there is a substantial diversity in education, income, and residential location. And these heterogeneity are particularly important because it determined the mobility capacity and the dependence of the elderlies. So looking at the mobility patterns of the elderly, the preferred mode of transport, we can see that private transport emerged as the dominant mode of travel. And public transport usage is relatively low, not because of the personal preference, but because of accessibility and comfort constraints. And for many elderly respondents, public transportation was it was perceived as physically demanding and unsafe and unreliable. So we can see that bus and auto here, bus, auto, and simple only the bus, these are included in the public transports. Infrastructure challenges. Looking at the infrastructure challenges of looking at the pedestrian infrastructure challenges. So the greatest challenge reported by elderlies was difficulty in crossing major roads, followed by inadequate footpath. Even though footpaths were there, they were often obstructed by the vendors, vehicles, and construction materials. And also there was pedestrians signals on intersection also. Lack of these signals also emerged as the greatest challenge. And challenges in public transportation. Lack of last mile connectivity and overcrowding emerged as the greatest challenge for the elderly, followed by absence of route information, insufficient frequency, and high number of boarding steps. And activity-based mobility among elderly. The concept of activity-based mobility captures that mobility not only means movement of people from one place to another, rather it involves how people move and for what purpose they move. Evidences from field suggest that the elderly, higher percentage of elderly move for healthcare and medical needs, followed by religious and spiritual activities, social and family related travel, daily rents and essential shoppings, recreation, and pension collection. This shows the travel dependency of elderlies. We can see that young elderly, that 60 to 69 years of age group, are more they travel more of independently as compared to older elderlies who are often always accompanied by someone. And males are more independent in traveling as compared to the females. And we can see that 48% of those elderly who are completely mobile, they travel independently, and 9% of them use aid for walking, and they are always accompanied by someone. And elderly are usually accompanied by their children and spouse, or both. Regarding the technology adoption, so smartphone ownership was 58%, and it was higher among the younger and elderly as compared younger and elderly and males as compared to females. However, smartphone ownership does not translate into being able to use the smartphone for using the app-based services. So, of smartphone users, only 76% of the elderly required family assistance for booking booking the rides. Like Ola, Ubers, and digital payment adoption remained low at 31%. So this created barrier for cashless transportation services. So mobility as a service was emerged as a major hurdle for the elderly. Now jumping to the discussion and conclusion, that the study highlights that elderly mobility in Gurugram is shaped by multiple and intersecting constraints like infrastructure deficit, transport design, socioeconomic inequality, digital exclusion, and governance gap. And these challenges are actually amplified by automobile-centric urban model. However, opportunities do exist through infrastructure enhancement, transportation innovation, and technology adoption, community mobilization, and progressive policy interventions. And the concentration of healthcare facilities in Gurugram and relatively higher elderly education level and emerging community initiatives provided foundation for improvement. And I would like to conclude by saying that elderly mobility must be addressed in urban planning, and policy responses should prioritize urban, universal, and age-friendly design, accessible and reliable public transport. So these are the references. I would like to conclude.
Yeah, thanks, Sumita, for highlighting these very important issues of elderly mobility in the urban settings. So as we will discuss at the end. And now we have the next presentation. It's by Pinto Paul, and he will be presenting on impact of adult children's migration on well-being of left behind elderly parents, evidence from an out-migration prone region in India. Over to you, Mr. Pinto.
Good afternoon, everyone. My name is Pinto Paul. Today I'm going to present my research on the impact of adult children's migration on well-being of left behind elderly parents, evidence from an out-migration prone region in India. So let me give you a brief study context. So as you know, internal migration, mostly labor migration, is huge in India, and that is mostly driven by urbanization and industrialization during the post-liberalization period. And if you see the census of India data, latest 2011 census, India has an around of 450 million internal migration, and that is 37% of the total population. So just briefly talk about the push factors of this labor migration in India, which is mostly poverty, unemployment, and landlessness. And I have taken the study context of Eastern Uttar Pradesh and Bihar, where there's a huge out migration, mostly in the western state of India, like Delhi, Gujarat, Maharashtra, and Punjab and Haryana. So when sometimes migrants can live with their families, but also there are migrants who leave behind their elderly parents and other dependents in their native places. So let me give you a context about the current aging and family system and elderly care in India. So as you know, India is experiencing rapid aging, and that is becoming a significant concern for the health and well-being of the elderly parents. And there is a shift from the traditional joint family system towards the nuclear families. And when the adult children, particularly sons, are migrate, the traditional support system for the elderly parents disrupt, and that can create and can affect significantly on their on their social, emotional, and material well-being. If you see the previous studies, most of these studies have found that elderly found that the adult children's migration has a positive impact on the elderly parents' well-being, and some of these studies also found a negative impact. And if you see particularly the context of India, most of these studies have found there's a negative association between the children's migration and the elderly parents' well-being and health. So my study specifically have two objectives. That is, first one is the association between the adult children's migration and well-being of elderly parents. Second is to understand the role of frequency of migrants visits on the well-being of elderly parents. Let me show you the framework of this study. So there are two different pathways that can impact the health and well-being of elderly parents. One is the positive pathway through remittances, and it can improve the living and financial conditions of the elderly parents. And then there's a negative pathway, and that can create a care deficit due to the migration of children, and that can further create loneliness, loss of caregiving, and lack of emotional support, and that can affect negatively on the health and well-being of elderly parents. Yeah, the data I have used is the Middle Ganga Plains survey, which is a cross-sectional survey conducted in Eastern Uttar Pradesh and Bihar. And the number of sample I have included in this study is 1,800 elderly respondents, 60 plus years of age. And among them, 52% are identified as a left behind elderly whose children have migrated for the work. And for the second objective, I have used the subsample of that left behind elderly parents to analyze the impact of frequency of visits by the migrant children on the outcome variable. So as you see, for the outcome variable, I have taken two different aspects of well-being. One is the satisfaction with material well-being, and that is measured from the four different dimensions, which is sleeping arrangements, clothes, satisfaction with the clothes, foods, and satisfaction with the toilet and bathroom. And from these four different dimensions, I have generated a index, and the score of the index is ranged from 4 to 12. Then I have a second variable called psychological distress. So there are 12 binary questions that determine the psychological distress of the elderly. So it captures the anxiety, low self-worth. So I am based on this 12 binary question, the variable score ranging from 0 to 12, with higher score means the poorer health, emotional well-being. So for the exposure variable, as I mentioned about the one is the migration of children, and that is categorized into two categories, which is left behind and non-left behind parents. Second is the frequency of visit by the migrants, which is a continuous variable. Then coming to the control variable, I have taken age, caste, religion, family type, landholding, living arrangement, marital status, working status, and state. Then I have used the ordinary least square regression method for the satisfaction with material well-being. And then secondly, I have used the a negative binomial regression model to assess the second outcome variable, which is psychological distress. As you see here, I have you can see the mean score for the outcome variable, two different outcome variable across these predictor, and you can see here the left behind parents parents are higher satisfied with their material well-being. The score is higher for the left behind parents. On the other hand, if you see the emotional distress, left behind parents have lower emotional distress. So, which is a very different kind of findings which I get from the previous studies that has been conducted in India. Coming to the regression OLS model, I have used for the first outcome variable, which is the satisfaction with the material living. And you can see with the consistency with the score that I shown before, left behind parents consistently have the greater or the higher satisfaction with the material living, and that is adjusted with the socioeconomic control variable. And then second variable I have for the predictor, I have taken the frequency of visit that has no significant association with the material well-being of the elderly parents. So if you see the positive relationship can be explained by the remittance effect. Most of the studies have mentioned that there is a economic impact of this migration, and that can improve the household economic condition. So here also there's a possible reason that remittance can improve the household condition, and that can reduce little bit of poverty and enhance the security, and that can lead to the higher material satisfaction. Then the second model is showing that left behind parents have lower emotional distress, which is also I get is a very different results from the previous studies. And secondly, you can see frequency of visits has a positive relationship. That means children who are frequently visit with their parents, they have a higher emotional distress. For the explanation, so mostly what happens when the children migrate migrate, they are for parents it is sometimes it is a kind of pride for them, and also it is a emotional reassurance from the children's financial contribution, and it is also because of the filial duties that they are doing through migration, and that can be internalized as a sign of upward mobility and family progress because of the migration. So if you see the cultural and social context of that region, it is particularly, migration is a family decision there, and remittances are seen as a moral and social obligations. And you see, joint family system still provides some kind of emotional and instrumental support, and there's a strong social network, community participation, and religious engagement that can help to cope up with this care deficit. So migration in this region, works as a psychological buffer, and as we see, there's a positive perception of migration, and that can act as a route to family prosperity, and that can reduce the stress related to the separation. So there's a sense of intergenerational reciprocity, among the parents that can strengthen their emotional stability and self-worth among these older parents. As you see from this graph also, there's a strong perception about the role of migration in the family and society. There's a strong perception that migration can bring prosperity to the family. Even it is higher among the left behind parents. So such kind of perception can generate from the remittances they receive from the migrants' childrens. Now coming to the frequency of visit, and that we get, there's a more frequent visit can lead to higher emotional distress. That can be possible because when elderly parents, they are ill, they are frail, they are emotionally vulnerable. Because and that time children can visit, frequently. Second is frequent visit can also remind parents of their children's absence and intensify the feelings of loneliness and temporary sadness. So that can lead to the higher emotional distress. So just to conclude my study is, so migration, as you see in this study, is children's migration has a higher, related to the higher material well-being and lower emotional distress. Secondly, frequent visit by the migrant children are linked to the higher psychological distress. So definitely, migration of children has a positive relationship in this study. But what is more important is that to it necessary to strengthen local employment opportunities that is still lacking, and it is also necessary to improve the social protection of the elderly and promote the community-based support system to support the aging population in migration-prone rural areas like Eastern Uttar Pradesh and Bihar. Thank you.
Okay, thank you, Mr. Pinto, for presenting your research and highlighting the important issues of left behind children. So there are certain issues, very important aspects that you have covered and that we'll discuss at the end. Now I'll just call upon the last presentations by Ms. Shawnee Das, and she will be presenting on the depressive symptoms and life satisfaction of across living arrangements in the elderly population of India, using I think 2017-18, I think last year data. Okay, Ms. Shawnee, over to you.
Good afternoon, everyone. Please let me know if my PowerPoint presentation is visible to all of you. Is it visible, sir? You are on mute.
PowerPoint is visible, but yeah, if possible, you can also put on your video.
Actually, it was not working. Then the presentation was like, because of the smooth presentation. Yeah. Good afternoon, everyone. I am Shawnee Das, a PhD scholar from the Department of Policy and Management Studies at Terry School of Advanced Studies, New Delhi. Today, I will be presenting my study titled Understanding Depressive Symptoms and Life Satisfaction in Various Living Arrangement Setups, Evidence from LASI Wave 1. This study examines how different living arrangements shape the mental and subjective well-being among elderly persons in India. So coming to the background of the study, globally, increasing life expectancy combined with declining fertility has led to a rapid rise in the elderly population. India is a very much part of this demographic transition. The proportion of elderly aged 60 years and above is projected to rise significantly, reaching nearly 323 million by 2050. While this demographic shift reflects epidemiological success, but it also raises a very critical question about whether longer lives are accompanied by better health, dignity, and well-being. Therefore, we can say that aging research has shifted its focus from longevity to quality of life in old age. Life satisfaction and depressive symptoms are two widely used indicators of mental and subjective well-being among older adults. Life satisfaction reflects how individual evaluates their life as a whole, whereas depressive symptoms capture psychological distress, loneliness, and emotional vulnerability. In India, changing family structures, weakening intergenerational support, limited social security, and rising healthcare costs further intensify the vulnerabilities of older adults. These contextual realities make it important to understand how living arrangements influence elderly well being. Therefore, this study has these two objectives. Firstly, to assess depressive symptoms and life satisfaction among elderly across different living arrangements. And secondly, to examine associations between living arrangements and psychological well-being. In order to assess this, in order to analyze this study, I have used the longitudinal aging study in India, Wave 1, which was conducted during 2017-18. Out of the total surveyed population, the sample for the analysis purpose consists of 30,795 individuals that falls into the age group of 60 years and above. Life satisfaction is one of the indicators which has been measured using satisfaction with life scale, and depressive symptoms are captured through the Center for Epidemiological Studies depression scale. And all the analysis has been done using Stata 17 software. Now moving on to the results section, this is the descriptive analysis, which clearly shows the disparities across different living arrangements. Elderly living alone report the highest vulnerability, with nearly half experiencing depressive symptoms and close to 60% reporting low life satisfaction. In contrast to that, the elderly who are living with spouse and children show considerably better outcomes with lower prevalence of depression and higher levels of life satisfaction. So we can say that this suggests that family residence continues to play a protective role in later life. Next is the logistic regression result for the association of life satisfaction among elderly across the different living arrangements. Here we can see that living alone significantly reduces the likelihood of reporting the high life satisfaction. Depressive symptoms emerges as a strong negative predictor of life satisfaction. Additionally, higher wealth status, better education, and urban residence increase the likelihood of being satisfied with life. These findings underline the combined influence of social, economic, and psychological factors on elderly well-being. Next is the logistic regression result for the association of depressive symptoms across the different living arrangements among the elderly in India. Here we can see that elderly living alone face a significantly higher risk of depression. Multimorbidity is another strong predictor, indicating the close link between physical and mental health in old age. Other socio-demographic characteristics like higher education appears to have a protective effect, while the oldest never married elderly and those with poor wealth are particularly vulnerable to depressive symptoms. Here I have the state-wise pattern. This slide shows that how there is a regional variation among the elderly population across India. States such as Tamil Nadu, Andhra Pradesh, Telangana, and Nagaland report a higher proportion of elderly living alone. And interestingly, states like Jammu and Kashmir shows high depressive symptoms despite fewer elderly living alone, which surely indicates that the role of broader social and contextual factors. Low life satisfaction is particularly prominent in states like Jammu and Kashmir and West Bengal. This study also includes certain limitations which I like to mention. Since it is still a cross-sectional data set, I cannot establish any causal relationship. Moreover, life satisfaction and depressive symptoms may also be influenced by recent life events and experiences beyond living arrangements. Despite these limitations, I am sure that this study provides valuable nationally representative insights. To conclude, elderly living with spouse and children report the highest life satisfaction, reflecting emotional security and care. Living alone emerges as the most vulnerable arrangement associated with low life satisfaction and higher depressive symptoms. A strong inverse relationship do exist between the life satisfaction and depression. education, health status, gender, and place of residence further shape elderly well-being. Overall, I would like to mention that companionship and living arrangements remain the key determinants of mental and subjective well-being in the later life. So, based on my study, I would like to recommend certain policy implications. There is a need to strengthen community based care and companionship networks for elderly living alone. There is also a need to promote age friendly infrastructure under the initiative of Smart Cities missions, integrating mental health screening into primary healthcare and enhancing social pensions and financial protection. I believe that such interventions are essential to ensure not just longer but healthier and more dignified lives for India's aging population. Thank you so much for your time and attention.
Okay, thank you, Ms. Shavani, for presenting us very important issues. Okay, now we have one more presentation by Mr. Vinit Kumar. So the topic is not with me. So Mr. Vinit, please go ahead and start.
Yes, sir.
Yeah, Xiaomi, you stop your sharing.
Hello, everyone. My name is Vineet Kumar. I'm a doctoral fellow, Banaras Hindu University, and my presentation topic is embodied devotion, daily practices of end of life migrants in the sacred city of Kasi. Introduction. Uh, in this presentation, we explore the profound spiritual landscape of Varanasi and Varanasi, known as the Kasi, and the we explored the Kasi through the lens of Dandi sannyasis and who migrate to this sacred city in the search of salvation. And we understand their unique practices, lived experiences, and cultural impacts of Dandi sannyasis in the Varanasi has spiritual seekers. And one statement is very famous in about Kasi, ki Banaras is older than history, older than tradition, even older than legend, and looks to it has all of them put together, given by Mark Twain. And Varanasi is an ancient city nestled on the banks of sacred Ganga River. And it holds a reputation as one of the oldest, approximately 3,000 years, continuously inhabited cities in the world. And Varanasi is rich in history and religious importance. As a prominent Hindu pilgrimage site, Kasi is believed to grant moksha or liberation from the cycle of birth, and lots of devotees came from across India and abroad for spiritual practices. And Varanasi has also a religious harmony where lots of spiritual people come for new insights and spiritual experiences and exploring Indian culture and traditions. And in the slide, who are the Dandi sannyasis as the migrants? Dandi sannyasis basically are mainly Brahmins, and only after a long training they receive a danda. It is a symbol of unity in mind, speech, and action. And following the 10 names of Swami order established by Adi Shankaracharya, and they preserve ancient Hindu philosophies and traditions through simple livings, and they pursue silence, meditation, and self-inquiry in daily life. And there is a complete renunciation of family, name, caste, and worldly attachments. And they typically wear saffron or gerua clothes, remain in simple attire, and the danda is always with them because it's a symbol of their oaths and discipline. And they resides in Vedantic ashrams or mokshadham institutions like Mumukshu Bhavan in Kasi, and they engage in Vedantic studies, meditation, rituals, and silence, and they avoid temple rituals, and they lived with minimum life, moving from place to place or staying in sacred cities like Kasi, Rishikesh, and Dwarka. And here you can see my field photographs of Dandi sannyasis and ashrams, and also a room of sannyasis and the group conversations of Dandi sannyasis. And here, my study focus on migrants and spiritual journey. Varanasi attracts to Dandi Sannyasi has the uh, destination for spiritual fulfillment and salvation. And in this study, we explore motivations behind migrations, and we understanding the religious, social, and personal regions of Dandi Sannyasis who came to Varanasi for spiritual fulfillment. And we explored also cultural and regional variations. And also we explored spiritual practices of Dandi Sannyasis and methodology. We used an in-depth approach for my study, and we conducted 20 in-depth interview of Dandi sannyasis at Mamukshu Bhavan, and we collecting the personal narratives and spiritual journey of Dandi sannyasis. And we did participant observation to understand daily life in ashrams and documenting routines, rituals, and community interactions. And we use historical text, religious scriptures, scholarly research on Kasi. And we conducted our field work over a defined period and used purposive random sampling for collecting the information of Dandi sannyasis. And in the study, we have a research problem, objective, and conceptual framework. My research problem is a limited understanding of Dandi sannyasis, migration, and spiritual integration in Kasi. And the objective of the study is to understand the importance of Kasi with the reference of spiritual mystic and explore the spiritual, social, and cultural dimensions, which is influencing Dandi sannyasis life in Varanasi. And for conceptual framework, we used some theories: migration theory, sacred space theory, Revenshtein migration theory, sense of place theory, attachment of place theory, and migration and mobilities theory. And my study have some cultural significance, which is shows the Dandi sannyasis, Kasi spiritual landscape. Dandi sannyasis add depth to Kasi spiritual life and preserving and practicing ancient Hindu traditions. And they are, and also inspiration for moksha seeker, and they lived with very few needs, avoid family life, and stay away from material things. And also their presence reminds people that Kasi is a city of saints and spiritual seekers. They help keep the city's sacred image alive, and also influences on local customs, and they support the spiritual map of Kasi. And my study have some a unique perspective. Varanasi have some spiritual pull factors like a holy landscape, temple, spiritual significance, Ganga Ghat, believe in salvation, and worship of Shiva. And Dandi Sannyasi enriches Varanasi spiritual environment. Their practices, beliefs, and presence in sacred spaces deepen the city religious atmosphere, gives identity as a hub for moksha seekers, and shaping its role a living center of Hindu philosophy. And it gaining a new insights into old religious practices by understanding the journey of spiritual migrants who come to Kasi seeking liberation and spiritual fulfillment. And here are some major themes and sub-themes on the basis of Dandi Sannyasis narratives. We structured some themes and sub-themes. My first theme is sacred geography and spiritual magnetism. It is divided into two sub-themes. Kasi has a moksha and spiritual magnetism of the city. And second theme is identity and renunciation. Sub-theme Dandi Sannyasi has a living philosophy and setting of social identity. And my third theme is daily life and spiritual practices. It is divided into two sub-themes: discipline and detachment, concept of self-knowledge. And my fourth theme is death, samadhi, and liberation. It's divided into two sub-themes: voluntary death, ichamrit, or preparing for death. And last is role of institutions like a Mumukshu Bhavan. Sub-theme is institutional ecology and institutional memory and record keeping. And this word cloud figure showing the significance of spiritual and cultural themes. The placement of words in the cloud reflect their thematic significance and conceptual frequency across the narratives and literatures and ethnographic elements we explored in the research. And larger words like spiritual, sacred, death, rituals, Vedanta, and Samadhi shows how central these concepts to the spiritual life. And here we can see some personal narratives of Dandi sannyasis. Respondent Dandi Sannyasi 1 is 76 years told that my ichha is simple, liberation, not rebirth. I have surrendered all identity, name, family, and attachments. This ashram, though small, is a powerhouse of energy. The rituals we perform here align us with cosmic order. Kasi is a mokshpuri, not a tourist destination. Its spiritual magnetism keeps me anchored. And respondent 3 is 83. This is a city, just a place. Kasi is a living consciousness. I walk to the Ganga every morning at Brahma Muhurat to dissolve the ego in her sacred waters. And my stuff is not a weapon, it is a reminder of discipline, austerity, and renunciation. In Kasi, death is not the end, it is the transcendence, and I wait not for death, but Mrityunjay, victory over death through realization. And next respondents said that my health is weak, but my spirit is strong. I came to Kasi because I want to die here. People say if you die in Kasi, you get moksha, but I believe living with awareness here is itself a blessing. And I try to remain conscious of every breath. And we have some another narrative of Dandi Sannyasis. Respondent 7A65 said, I left my family 40 years ago. Since then, Kasi is my only home. I wake up 4 a.m., bath in the Ganga, and sit for meditation till sunrise. Death is not something I fear here. It is the part of the process. I came to Kasi to let go of the world, and every ritual I do here takes me closer to peace. And next respondent says that before coming to Kasi, I wandered in many places, but only here I found spiritual magnetism. My ashram near the ghats is filled with the sounds of chanting and temple bells. These sounds calm my heart. Every step I take here feels like yeah, walking in a living scriptures. And last respondent says, I used to be a landlord in Rajasthan, but death of my wife changed everything. I came to Kasi to die, but the city gave me life, a spiritual life. My ashram near Assi Ghat is my last home. I wear only Gerua clothes, eat once, speak less, and pray more. The Ganga is my temple, and every sunrise brings a moment to cleanse the karmas of lifetimes. Here in Kasi, even the birds chant Om. And here we'll discuss about some implications and future research. So due to modernization, salvation process are changing. So my study is preserving the existence of old process of salvation in the ashrams of Varanasi. And it will be helpful researcher who are working in religious and spiritual studies. And my studies also will be helpful for understanding various holy landscape, migration, motivations, lived experiences, and Hindu methodological importance. And here some conclusions. Varanasi has a spiritual magnet which attracts some Dandi sannyasis, came for salvation seekers, came for moksha, and Dandi sannyasis play an important role in the sacred city of Kasi. And migration has a key lens of where we can see the trend and patterns and the importance and the motivation behind the migration. Thank you.
Okay, thank you, Vineet, for the good presentations. Now we are reached to the at the end of this session. So let me briefly summarize the session and we'll conclude this. So let me start with the paper by Saurabh Mandal. Yeah, Saurabh Mandal is he has talked about the aging without care, the rise of elderly-only families in West Bengal, and he documents the growing prevalence of elderly-only households over 3 decades, linking it to declining fertility, family supports, and increasing care vulnerabilities. And the second paper by Sadanand Kaur, he wanted to explain the educational gradient and cognitive health and shows that the higher education attainment is strongly associated with the better cognitive health in middle-aged and older adults in India. The third one by Anil Paul, and he has presented his paper on socioeconomic determinants of social support among elderly in Uttar Pradesh, and he compares the elderly living in old age homes and the family settings, revealing how income, education, and living arrangements shape access to the social support. And the fourth one is on bibliometric analysis of aging in place research by Mr. Shubham Sharma, and he maps the global research trends, key themes and knowledge gaps in aging in place studies within the gerontological literatures, and he put together all the research specifically on aging in place. The fifth one is on challenging the dependency narratives by Mr. Raghunath, and he highlights the often overlooked economic, social, and caregiving contributions of older adults, reciprocity, and intergenerational solidarity. Generally, we think elderly are the dependent, but they can also be an asset for the family in any ways, and can contribute to the well-being of the family, and that is why he has shown with the reciprocity of the care. Now we have another presentation by Ms. Sumita, and she has presented on mobility among the elderly in Gurugram city. Gurugram, and she examines the urban mobility pattern, identifying infrastructure, health, and safety challenges alongside opportunities for active aging. Activity-based mobility will be dependent. And there are certain issues that we just wanted to know, that activity-based mobility will be again depend on the age of the elderly, because if the younger elderly or the young old people may be mobile because of they are active and they can mobile easily for different reasons, but those who are oldest old, for them it's very difficult and they may not frequently travel. So for them, the traveling is depending, or mainly they are going for the care services or to get the healthcare services. So whether you have considered the age factor while considering this mobility. The next presentation by Mr. Pinto Paul, and he presented his paper on the impact of adult children's migration on elderly well-being, and he demonstrates that the children's out migration negatively affect the emotional, physical, and social well-being of elderly parents left behind. And the left behind parents are showing, but there are certain, or we can say the findings that is that sometimes it's very difficult to digest, like left behind parents are showing higher life satisfaction than the non-left behind parents. The another one is more visiting children will have higher emotional distress than those who are not visiting frequently. So these are the findings. Sometimes it's very difficult to digest, but I don't know how, so that Mr. Pinto may throw some light on this. And the next presentation by Shavani, and she has presented on depressive symptoms and life satisfaction across living arrangement, and she analyzes how living arrangement influence the mental health, showing higher depression and lower life satisfaction among elderly living alone. And the last presentation by Mr. Vinith, and he presented on the embodied devotion, the daily practices of end life and migrants in the sacred city of Kashi, and he has showed how these sannyasis go to the Kashis for the salvation and stay back, and they realize this is the best place to stay and spend their last phase of their life at the sacred place in Kashi. Okay, so to conclude, the papers presented in this session highlights the shifting family structure, migration, educational attainment, and the living arrangements are reshaping the well-being of older adults in India. The discussions underscores that the socioeconomic inequalities, combined with cultural and regional contexts, it continues to produce uneven access to care, placing older persons, particularly those living alone or left behind by migrating children, at greater risk of social isolation and mental health well-being. At the same time, this session effectively challenges the dominant narratives of elderly dependency by demonstrating the continued social, economic, and emotional contributions of older adults within families and communities. Practices of reciprocity, solidarity, and community engagement emerge as important protective resources in later life. Overall, the evidence points to the need for context-sensitive, inclusive interventions, including age-friendly planning, strengthen community-based support system and policies that support aging in place while addressing the specific needs of socially and economically vulnerable elderly populations. So I thank all the presenters for their valuable contributions and the participation in these sessions. And one more thing, I just wanted to say that everyone has presented very good papers, and I hope that there is chance of getting published. And we are also planning to bring out these publications. And if you are interested, you can also share your final paper with us, so that anyway, that mail will go to you, and we are asking you to share your paper. If you are interested, you can share your papers with us. So now this is done from my side. Now I'll request Dr. Dilip to give some remarks. Over to you, Dr. Dilip. Thank you.
Okay. Thank you. So it was also an excellent session. We had an opportunity to listen a lot of empirical as well as analysis. Okay, so just a quick. So as I mentioned earlier, our input is only, you're giving inputs only, it is for you to decide whether you, because you also should get some feedback after presenting in a seminar. So the first presenter, say Saurav, so he is able to illustrate the rise in elderly only families, okay, using various rounds of NFHs. Okay, so my question to Saurav is that whether I am clear about NFHS 1 and 2. They don't interview households without women in the reproductive age group. So 5, 6 and all, I don't know. So how can you study this particular thing? If there is no women in the age group, reproductive age group, earlier they never used to include that household for the NFHS survey. So your analysis, no. So it to a certain extent it estimates may be a little off. So you have to check that. Okay. Have you checked? Saurav, are you there? Okay. I think he is not there. Okay, so Sadhanand's paper is very, very interesting. Where the gradient which he showed with the cognitive score differentials by education, this thing. So that is really interesting and it can be published also. One more thing you can see, how much of that gradient that you see is because of the inability of those with less educated population in understanding the questions related to cognition. Okay, the questions related to cognition, it is not that easy for even a person who has completed 10th standard. So you can just see that, test that also. Okay, so sometimes, of course, you have seen a very good relationship is there, but to a certain extent, it could be because of that also. Okay, so and Anil Kumar Pal's paper on where he analyzed the social support among elderly in 2 settings, that is those who are living with family and those who are living in old age home. So he has done a very challenging work meeting people, 184 persons from each group. Okay, so that even the results are also very interesting. So, but can we expect social support in the case of institutional population? So it is anyway, those who are living in institutional surrounding now are most likely to be those without that social support. Okay, so, but other than that, the paper is very interesting. And this thing. So the third paper is by Shubham Sharma. So that is a excellent paper. He has given the full landscape. So what is the landscape of research on aging? The changes in that. And only one comment is that some journals and all you have listed based on citation, things like that. I think that that ranking might change depending upon number of issues that a journal will have in a year. Some are biannual, monthly, so some sort of, or you can citation per volume, something you can per issue like that. You standardize it when you show that in a table. Okay, otherwise it brings out the nature of change, the things that are becoming more relevant in the case of aging, some of the things which have become redundant, all those things are very explicit. Okay. Then Raghunath's paper challenging the dependency narrative, I think that is also full of insights on the existing narrative. No, it is where they treat elderly as a dependent. But we have to also, the paper clearly acknowledges the contribution of the elderly to the society. Similarly, they have to be treated with dignity. Their contributions have to be acknowledged. So that perspective that brings in, that is, his paper brings that into the context. Now, Sumbaita's paper, which addresses a very important problem on mobility among elderly. She brings out the issues related to mobility that elderly face in Gurugram city. So, Gurugram is a urban city with infrastructure, everything very good. So, the things may be even worse for the elderly in other cities and even further worse for those living in rural areas. That is what I see. To make it more focused, when you say mobility, you have to have a boundary of the definition of the mobility. Okay, so you put a clear definition of the mobility. What do you mean by, what are the things that you include, travel or whatever? There are certain things which are near the boundary, like smartphone, digital payment, all those things. Whether you want to bring it under mobility is a different question. So that, of course, you have to be careful. So you deal with things which are directly related to their mobility. Other ones, if you want to include, you need to have a clear justification why I am including them when I describe the mobility. So this Pindu Paul's paper on impact of adult migration on well-being of left behind elderly parents. That analysis I liked because it had a framework and he tried to explain every aspect. In the beginning, I was thinking why he is only looking at the negative aspects, but it is very much balanced. And even I should congratulate him because even when he found a association between frequency visit and positive association between frequency of visit and emotional distress. No, he tried to explain because why is it so? So that is one of the highlights of that particular analysis. He tried to explore the issue in detail. Okay, so that I really compliment him for that type of analysis. Okay, the Shanoyi thus made an excellent presentation on depressive symptoms and life satisfaction using the LASI data. So this comment is not only for Sanohi Das, but some of the those who are using LASI data. Okay, so you have used this 45 plus whatever that sample that is available in LASI and calling it as elderly. Why do you call 45 to 65, 60 population as elderly and do the analysis? Okay, so for LASI, including 45 to 60, there is some reason for that. LASI, you should know that LASI is a longitudinal survey. So after they have the next round, then half of them in the 45 to 60 will cross to 60. So they can study the process of aging in the next, but in the third round, all of them might have transferred to the elderly age group, shifted. Okay, so that is why it is there. You have a 60 plus age group, you want to experience using a cross-sectional data, you only use the 60 plus population. And the last presentation by Vineet Kumar, it was very informative and also it gave many of us, including me, the something, our understanding about the Dandi sannyasis has all increased. Okay. As a researcher, no, I only feel that, do you really, for a Varanasi resident, the Dandi sannyasi may be a migrant, okay, or a geographer or somebody who is working on migration, they see because their place of residence is different from where they are found during survey or census like that. So you can call them as a migrant, but from a right perspective or something, no, they are there because it is their lifetime wish to die there. So calling them migrants, I know you may have to have some other term. Okay, actually, from inside, they want to die there. So they come there, it is their ambition. So for researchers, they may be a migrant. For them, that is the number one thing they want to have. That is why they are there, unless it is not forced. Okay, that is all what I can comment on your thesis. Other things, still I am getting trying to digest. It is very excellent paper. It was very informative also. Thank you. I also like to congratulate all the authors for this very interesting session, and I hope you take all the comments from both Professor Dhananjay and myself in the right spirit. Okay, thank you.
Yeah, thank you, Dr. Dilip, for giving them very good comments, suggestions. I think we have reached to an end of the sessions. Divya, do you have any instructions to give, or we should close this session now?
We are good, sir. Tomorrow we'll start sharp at 10 a.m. So 10 to 12 o'clock will be the sessions, and 12 to 1 we will have the valedictory.
Okay, so tomorrow morning session will start at 10 o'clock, and afterwards, once the technical session is over, the valedictory will be there around 12 o'clock. So thank you all for joining these sessions, and we'll hope that tomorrow also we'll see you all. Thank you very much. Bye-bye.
Bye. Bye-bye.
Thank you, sir.
Thank you. Thank you, sir.
Thank you.